This learning has to be extended beyond this PowerPoint presentation to hands-on, and it needs to be brainstormed according to the individual needs. It does take time for you to consolidate, and so the more thorough you are, the more helpful you are to the patient. So I chose to use the word ultrasound ERT. Sound ERT means high quality assisted reproductive technology. And then you're engaging ultrasound into it as an aid for couples to become parents. It so happens to be, that's the name of the company that I registered in UK. 𝗑𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗑 you to connect either for your own carrier, your own patients, or patients can directly connect with me for me to respond same day, either career advice or the care for their any medical ailments they have. And that's my mobile number, WhatsApp number. This is part of the company that I envisage for the next 10 to 20 years, whatever energy that I have left with, to provide preventive gynecology and preventive obstetric care, or reach out ambulatory gynecology, ambulatory obstetric care. It's structured into overall health, ATM, adolescent to menopause, couples to become parents, miscarriage care, early pregnancy and preventive obstetric care, authentic information, and the overall health. That's whatever I'm going to teach today. It's not that what I know. I have no intention to keep on talking about what I did in the last 30 years scanning women. I would appreciate at some point, I want to spare some time for you to interact with me. And so please be open-minded, like this cup at 6 o'clock, so that you can earn and learn something today. And I obviously don't know who needs more emphasis on certain parts of the ultrasound, whether it is a level 1 learning, level 2, level 3. Somebody individually needs a specific learning activity. So I encourage all of you, don't close the chapter by just finishing this for an hour lecture. We're splitting this lecture into kind of 3 segments. I'll do the overall, but in between, when the value of ultrasound in monitoring follicles come, Dr. Meenal will present, and that data will be the book chapter that we wrote together recently on how to effectively or diligently use ultrasound in stimulating ovaries. So this is the general format for today. Everything what we live, every minute should be meaningful. People come for a specific expectations that there is something stopping naturally for them to become parents. In the context of that, a male might have different departments that's gone wrong, and female might have had different systems that are contributing to the infertility. And as a couple, there might be unique problems that is the cause of their infertility or miscarriages, and so on. Your job is to identify, use the ultrasound or any other tool for that matter to improve the diagnostic accuracy, and then you open the door for therapy. The diligence of diagnosis is the key. Most successful treatments depend on most accurate diagnosis, but there isn't a single diagnosis. Biology is a Pandora box. Anybody who stick to one diagnosis is likely to run into trouble at some point in their career. You must always be mindful of the differential diagnosis, and you must be mindful of limitations of ultrasound, contrast ultrasound, 3D ultrasound, hysteroscopy, laparoscopy, even IVF PGT. Every technology has limitations, and nature is far more powerful than whatever diagnostic technology as well as the expertise. We need to be mindful of that for you to be sustainable, evolving the biological evolution. Not to waste infertile couples' time, there is a model that I will be emphasizing on, one-stop fertility assessment or infertility assessment service that does involve structured history taking even before the patient comes, scheduling the ultrasound in the mid-cycle, which will allow assessment of the large component of the endocrinology. You can always do tube test at the same time. You can assess the myometrial endometrial pathology at the same time. You can do a complete assessment of the male in terms of the structural, endocrine, and ultrasound assessment of the testis. as well as the psychosexual dysfunction. This eventually, in the single one-stop fertility or infertility assessment approach, will give you 3 outcomes. You can assess the potentiality of this couple to create a healthy embryo, and the potentiality of that lady to accommodate an embryo, and the potentiality of the uterus to nurture the embryo to full term. And this, to a large extent, can be in a single one-stop infertility or fertility assessment. It can be even home service or reach-out service. A couple of things I'll be introducing specifically here: contrast ultrasound with air, which I coined the name air contrast salpingography. In this, what you will see here is the you can see ovary here. This happened to be the left ovary. So if you can see me, you're looking at the left adnexe of the ovary. Say I'm the patient, and this is the left adnexe of me. All right. So the ultrasound is facing in the vagina, facing the left ovary. And if the tube is open, that is visible by the air reflected on ultrasound, you will see a line flowing through. And sometimes you will see the white shadows circumferentially spreading around the ovary. So these are the few follicles in the left ovary. So what you see, this line here is the air traveling through the fallopian tube, reaching to the left iliac fossa or ovarian fossa below ovary. You don't need color Doppler to test the tube with air contrast salpingography with ultrasound. But that's something that sometimes you can make use of. So as you can see here, this is the white area. So uterus is at 9 o'clock place here. This is below the left ovary. And then it's going below the ovary all the way. You can see 8 to 10 centimeter, and you can see the white air falling out. As you know, air is 100% reflects the sound, ultrasound back. That's where you get to see. Follicles as a fluid, you don't get to see anything the ultrasound goes through. So that's the black. So this is just to say air contrast salpingography. Since I started using it, I stopped saline salpingography, and I rarely do hysterosalpingography. Of course, laparoscopy and dye test has a unique gold standard role to play for those people with this complex pelvic findings. You can always use that too. So that's just 𝗂𝗁𝗍. That's something that you might have not be that familiar. It's quite simple to introduce. I introduced the word 𝗂𝗁𝗍. My colleague in Amsterdam, prior to this, introduced exam gel, which is almost $200 the cost. And that is called HIFOZ, hysterofoam salpingography. Now, in this one-stop fertility assessment, I want to get simple male assessment out of the way. If you scan 10 ultrasounds of the scrotal sacs for your own staff today itself, or tomorrow, whenever you have access with a linear probe or a curvilinear probe, when you see 10 normal men who are fertile, you know how the testis look like. You're actually taking the organ into your hand, and then you're just scanning by touching. It's much more easy to scan testis, and you can always see the veins around the spermatic cord. So, and with hand, you should be able to feel the vas. So any of you can easily acquire how to see the testis, normal, abnormal, normal location, and the veins. So male assessment in the one-stop fertility assessment is quite straightforward. And obviously, that's part of the one-stop fertility assessment service. A vein, which you will easily see just below, is almost like a subcutaneous veins. You can see your own veins there. You just put a probe, and you're able to see. You don't need TVS probe for that. You just need an abdominal probe. You're just spreading over, and you will see the veins like that. That's an abdominal linear probe. You just see it. You will see the veins exactly like this. The veins are more than 3 millimeters with or without Valsalva. It is severe varicocele. And if it is bilateral, then there is a recent publication from none other than one of the greatest andrologists ever we've known, Dr. Rupinlal Shaw, Indian origin, with multicentric multinational trials. They have published less than 6 months ago that if there is bilateral varicocele, severe, 3 millimeters or more, doing microscopic venous ligation will improve sperm parameters significantly. They haven't done the trial yet to say actually the improvement in the sperm parameters actually results in a higher live birth rate. And that's something needs yet to be established. In the same way that you're doing one-stop infertility assessment using ultrasound and contrast ultrasound, because I deal with recurrent miscarriages, recurrent implantation failure, and that's been the last 20 years of my focus area of interest, I do include the ultrasound in the recurrent miscarriage service. I call it as abnormal uterine bleeding service or one-stop uterine factor assessment service, either in the infertility. We are used to check the tube. We are used to check the ovary. Now I want to introduce uterine factor assessment service within the part of the one-stop infertility or fertility assessment or miscarriage assessment service. That includes, obviously, the great history taking, a proper protocol, standard operating procedure, which I can share. I have 52 algorithms ready handbook on ART. Kindly email me if you are interested to extend your knowledge of what you learned from this webinar. You will not regret. I will be hand-holding you to reach a point of clarity in your practice in ART or office hysteroscopy or male infertility or ultrasound 2D, 3D, 4D until you are satisfied, and that's a promise. It's always very simple. I use a lot of layman language. I call ABCD model. If some of you made familiar British Medical Journal, I was very, I find it why they write ABCD of pelvic pain, ABCD of epilepsy, ABCD of attention deficit disorder, ABCD of infertility. I used to think why they made everything so simple. Now that applied to very well. It's like farming. A farmer only knows the strength of the plant, strength of the soil, which plant to put in the which soil, and also the overall health. This 4 ABCD model is what I manage even 20 miscarriages or 20 implantation failure or infertility or fertility assessment. So I just stick to a very simple layman format. So that's the ABCD form of in the fertility pathway, you're going to distinctly use ultrasound to get the best out of the diagnostic information. And I emphasize, I am assuming all of you are ERT practitioners, and our job is to give 90% pregnancy rate, if possible, for those green profile patients. Green profile means there is a good quality oocyte competency, good quality sperm competency, and uterus was competent, and there is a good compatibility between the male and female. So, and what is the evidence for that? 98% of the children on an average on planet Earth are born without seeing any doctor. So there's something right about this 98% of the world population. So whatever nature is doing, if you can learn it and implement in an IVF lab, which means IVF lab is nothing but fallopian tube. So if you can replace everything what fallopian tube has done, so the egg and sperm meeting and fertilizing and becoming blastocyst and hatching is taken care of. But then uterus has to be normal, the soil has to be normal, the living room has to be normal. So I say use this ultrasound with 90% authentic information. If you say it's adenomyosis, it should be 90% authentic. If you say myometrial pathologies, endometrial pathologies, Doppler pathologies, ovarian reserve problem, PCO, whatever diagnosis you make with your ultrasound, it should be 90% accurate. And having diagnosed the condition very well and having picked up the prognosis, if it is red, even if you do 10 IVFs, forget about ultrasound or hysteroscopy or IVF PGT, and you're in practicing medicine in the top 5 centers in the world. The prognostic criteria of the sperm, egg, uterus, endometrium, and their compatibility dictates the overall success, no matter which planet you're practicing ART. So you must be aware of that, knowledgeable to that, and that you have to convey to the couple at the outset. So competency of the embryo, both nuclear and cytoplasmic competence of euploid blastocyst, competency of the endometrium, myometrium, and then the communication between the embryo and endometrium. All of them in the green range, you will get success rates in the order of 70 to 90% in most good units. Obviously, red category uterus, red category myometrium, red category compatibility, red category sperm, red category egg, red category laboratory, which means not a standard laboratory, not a expert people running the show. All of them can contribute to red category, and most centers are in between. So it is the prognostic ingredients that dictates the outcome. Of course, human error plays a large role. So within this context, as you can see here, we do simple scan, which has a good correlation. We do contrast scan, which is saline or gel. You can use distilled water or so on and so forth. And then you until you become good in sensitivity, specificity of your simple scan and contrast scan, you must be using universal hysteroscopy in any ART facility. This is the prognostic criteria. This presentation will be shared with each one of you. And those whosoever want to learn, they always learn. I have no doubt about it. So I'm just giving the material. I'm not going to emphasize on non-ultrasound components of ART. But ultrasound is just one puzzle piece in the entire puzzle total. So if you're doing a good diagnosis and good treatment, even in UK, if you say that, whether it is prognosis related, whether it is center related, I cannot be sure. Within UK, the pregnancy rate can be 52% or it can be 18%. So no country is great or no country is worse. It depends on the prognostic ingredients of the couple. But typically, if you assessed it and you are sure it is a green category couple, sperm, egg, and uterus, you need to be able to give live birth rate of 73% or so with less than 2 embryos transferred. Not necessarily euploid embryos, but that is the benchmark you have to set up if you want to call yourself as a first-class service provider. Within that, I will see how diligently you can use ultrasound. Because ultrasound is your entrance. It's almost like a receptionist. If the receptionist misbehaves, that company's performance, the customer service will be compromised. So basically, the two-dimensional ultrasound, tissue contrast, I call it, which is a normal scan. You see 18 shades of white. That's called ultrasound. There is 18 shades on your ultrasound. You will notice that every ultrasound machine will show it up. Your eye should be able to distinguish 18 shades of white. That is called tissue contrast. Then you have liquid contrast, and it can be 3D. And you have air contrast. So there are 3 types of ultrasound that we're going to discuss. And the images that I'm going to share, most of them are in the Resono family. I do have some images, but 90% of these images are Resono 7, Mindray, since 2018 that I'm exposed to this technology. And in the last 2 years, it's the new i9. So why I'm saying this is the typical tissue contrast. And this is the 3D, which is nothing but anterior-posterior view of the uterus. This is sagittal, right sagittal. That's left sagittal. That is axial view. So this is the anterior-posterior of unicornuate uterus, septate uterus, arcuate uterus, and funny-shaped uterus. It doesn't matter. And 3D technology is such that now, even without liquid inside, you can see the beautiful endometrial polyp by just rendering the machine very well. It takes 20 seconds for a 3D. This is a 3D probe I just broke off from an old machine. It has got a head that goes like a chameleon all around. Eyes goes like a 360 degrees sort of thing. So it'll take an MRI plane in 20 seconds. You don't need skill for that. It'll take it on its own, and then you can sit down and render it at your own convenient time. So if you're using, you can see even without contrast, you can identify the polyp, the height and depth and measurement of the polyp. And this is a 3D contrast scan with around 3 ml of saline inside the uterine cavity. What you're seeing is the uterine cavity, the black thing. And this is the endocervical area. There is a tiny mucosal polyp here. You can call endocervical polyp. And these 2 lesions are adenomyosis in the making, which is endometrium infiltrating into the myometrium. So that detail that you can get with a 3D contrast scan. And then if you take how the contrast scan looks like, if you want to just have a look. you may think, these two endometrium are suitable for embryo transfer, and you have a beautiful euploid blastocyst with a great embryologist and a great embryoscope. But you see this endometrium is polypoidal endometrium. If the embryo implants on the polypoidal lesion, it may not implant because the metabolism of hypertrophic or hyperplastic endometrium is unlikely to be implantation friendly. And if the embryo is lucky, it can implant on a flatter area. I'll take a laser pointer here. So as you can see, in a flatter area, it may be lucky it can implant. If it implants on the polypoidal endometrium, which you cannot see in a simple 2D scan, you have no way of saying, so it becomes a pot of luck. Whereas on the other hand, the same luteal phase looking endometrium, it doesn't matter endometrial thickness. It's a homogeneous luteal endometrium. You can see there is no endometrial pathologies. There is no uneven growth of the endometrium. So that's the endometrium that you want. So I can quote the Center for Reproductive Medicine, CRM London, which is in the top 5 centers of highest clinical pregnancy rate in UK for a number of years. They do universal 3D contrast ultrasound before first embryo transfer. And they published 13% excess pregnancy rate in British Fertility Society conference. In the same note, if you're doing universal hysteroscopy, even before the first IVF, you have minimum 25% excess live birth rate. So waiting for things to go wrong and then do the 3D scan and then do hysteroscopy needs to be abandoned, according to my experience. So I want to make this visibility small to go somewhere. So the other thing that I'm going to introduce, maybe that you are already doing it, air contrast salpingography. As you can see, this is the right fallopian tube. It almost looks like a 3D print. And this is just air in the right fallopian tube, including the fimbriae. You can see the narrower diameter of the fallopian tube. So I don't use HSG anymore, saline scans anymore for fallopian tube. Obviously, there are specific indications to do HSG still and laparoscopy still, but this is the one I use 90% of the time to assess the fallopian tube by just giving a diclofenac rectal suppository, giving an informed consent, and doing it, obviously, excluding the infection and so on. So once I am fond of, obviously, as you can see, I always take this to all over the world where I'm scanning, whether I do mock embryo transfer teaching on specimens, even I carry hysteroscope to say how I perform, even I do ultrasound guided hysteroscopy to minimize the perforation. So there is an ultrasound machine wherever I go, and almost like a laptop, portable, the standalone, and now handheld. You have Clarius company, you just use the TV probe with your smartphone, and you can complete a TVS assessment, as well as the abdominal 3D ultrasound of fetal profile also. So I just want you to be appraised of where we stand, and your patient should not be second-hand citizens getting second-hand care. If you don't have it also, tell where the world is heading and where it's available. You can always be the good interface between the patient and the science, rather than giving what only you have. So you need the knowledge of how to exploit the technology. You need training, you need experience, you need the good equipment, you need appetite for excellence, and that should be quality driven, and you must audit. I will explain a couple of examples on the audit that I've done on difficult embryo transfer. What is the role of ultrasound and hysteroscopy? Difficult embryo transfers, what is the role of cervical canal assessment, and so on and so forth. And obviously, you should have unrelenting attitude to unconditional serving. Not that she pays, only then we give it. At least we can give a good advice independent of the paying capacity of the patient. So I currently use 𝗀𝗏9. I run training programs all over the world. I just want to emphasize here, if you're going to do saline scan, you need to occlude the external os. If you want to build pressure inside the uterus, you need to occlude the internal os so that you can, the pressure that you build in the uterine cavity can open the fallopian tubes, which are muscular sphincteric structures. So you must be aware of what as accessory material you use to do saline contrast scan, you can just simply occlude external os by using any cone that you use for your laparoscopy. Any cone, you can just occlude the external os and use the saline scan so that it doesn't occupy the uterine cavity. And if you want to build the pressure inside the uterine cavity so that the pressure, 80 millimeters of mercury, will allow the fallopian tube to allow the liquid to flow through or air to go through, you need to occlude the internal os. And these are the quality of images that you get with the current 3D, which I have never seen before in my career. Yolk sac circulation, placental circulation. Amazing technology is available in the machines. And I introduced a word called bimanual transvaginal scanning because once you put the probe in the vagina, don't expect probe to reach the region of interest. You bring the region of interest close to you. That is the advantage of any gynecologist. We know how we manage ppH. We squeeze the front and back of the uterus with your hand. So you can bring any structure close to the probe because vagina is a tamponade. You know, it will not allow the probe to go anywhere you want, but you can bring the structure close to your organ. Then you can make the head end of the patient to go so low, entire bowel will push away, and you will have no bowel to interrupt between the probe, ultrasound waves, and the organ of interest. If there is, other than liquid is between the probe and the organ of interest, you will lose the quality. That's why you get inconclusive findings. So if I'm going to go through this list anyway properly, this is my template. If you see almost 32 points I see in 5 minutes. This is my master ultrasound template. It's there in the slides I'm going to show you. But you will be filling that to say at some point, sorry that I could not see very well. Ultrasound is no longer valid. Then I go to MRI, then I go to CT scan, whatever it takes. I'm sure you all understand. We still use MRI for fetal medicine or fetal sonography because ultrasound has limitation. MRI is its bit advantage. And then your senior opinion has another input. So there is no saying that dogmatically buying an expensive ultrasound machine and your whatever 𝗨𝗁𝗁𝗁 or FRCR, it doesn't make the diagnosis accurate because pathologies don't allow ultrasound to reveal itself into a large extent. So I have a video also by cutting vegetables. I teach people how to take the good plane of XYZ, but that's something. Training is a hands-on training that we will do. So the purpose of ultrasound to see what normal pelvic organs should be there. And that's with scan, contrast scan, with hysteroscopy. I do vaginoscopic hysteroscopy without sedation, 80 to 90% of the hysteroscopes, and use contrast scan to identify neonatal pathology in the OPD. And there is a very high correlation between ultrasound to contrast scan to hysteroscopy. But hysteroscopy is unique because blood vessels cannot be seen by ultrasound and the glands cannot be seen by ultrasound. So please do not confuse the distinctive merits of each diagnostic tool. Hysteroscopy is the gold standard. Ultrasound is a very good indicator of endocrinology. In the mid-cycle, if you call her, you see a dominant follicle, you see 8 to 10 antral follicle per ovary, you see a beautiful myometrium and endometrium, and it does confirm hypothalamo-pituitary-ovarian uterine axis for sure. If these 3 lines are equal, they're just estrogen is there. If the outer 2 lines are thicker, there is early luteal phase. If all the 3 lines become completely white, the progesterone is at least 12 to 15 nanogram. So I've done this over thousands and thousands of patients. So ultrasound has a high correlation to the endocrinology. Therefore, I encourage mid-cycle scan to be your opening. I don't routinely do FSH, LH, AMH because I can count antral follicle. I don't need AMH always or LH. There's no clear indication for that. And there is a high correlation of ultrasound to the histology and hysteroscopy. So proliferative phase, luteal phase, proliferative hysteroscopy, luteal hysteroscopy. I only do hysteroscopy in the luteal phase for that matter. If the patient doesn't have regular cycle, I use FET protocol, frozen embryo transfer protocol. So idea is to see the normal things are there, and the idea is to see abnormal things are there or not. If so, how significant is the abnormality? So ultrasound will be spread out, consultation ultrasound, baseline ultrasound, monitoring ultrasound, ultrasound guided procedures, and ultrasound in the early pregnancy because patients expect us, IVF clinicians or a fertility or primary care, secondary care, tertiary care provider of the infertility services, they expect us to at least give a clean sheet that, pregnancy is there, pregnancy unknown location is there, ectopic is there, miscarriage is there, only then to discharge to an obstetrician. It may well be that you are the same obstetrician who will be delivering also, but you need to just to arbitrarily classify the role of ultrasound in all this. So this is the sheet that I showed you. There are about 32 different things I see. And individually, I just want to split them into all these individuals. So I'll take time to assess uterus anteverted, retroverted, axial. If it is axial, you're at the feet of ultrasound. You won't be able to see anything. Trust me. You will get, if you're going through the cervix, you rarely see anything properly. So your best shot is to be in the front of the uterus, you probe, or on the right side or left side. Of course, you can see certain things if you're on the top, because it will give you the axial view. But if you're at the cervix, and no ultrasound can traverse through the cervix to display any structure, so you're almost gone. So you need to try to go in the anterior fornix, posterior fornix, right fornix, left fornix, bring the uterus down, do the Trendelenburg, anterior Trendelenburg positions, whatever it takes, right lateral, left lateral, get as many things, empty the rectum, put the saline in the vagina, everything possible to get the best black contrast against white ultrasound. So I'll be going through in this format, and as much as time permits, I will cover examples for section 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So I always tell people, make it simple. I hand over this report to patient. Anywhere in the world, they can use this. Every doctor will benefit if you take responsibility, make a signature, put a date, and you're telling action plan. When you finish ultrasound, this should be your action plan. This will be your summary. What you're doing, she is suitable for vaginal egg collection or she is not suitable for vaginal egg collection. Why? You found ovaries cannot be reached safely. There are blood vessels in between. There are fibroids in between. Okay, so your report should reach this point of clarity that this patient is suitable or unsuitable for transvaginal egg collection or suitable for transabdominal egg collection. Now, by assessing the cervical canal, cervicouterine canal angulation, I've done the randomized trial on that in Cambridge, that you can predict difficulty in embryo transfer and IUI due to abnormal cervicouterine canal. Within the canal, there may be lesions. I have a separate presentation on correlation of ultrasound to hysteroscopy, but let's see how we get on. I just want to give you the overview today, and anyone interested, we can do another webinar. That's not an issue. But it depends on appetite for excellence that drives you to be excellent in what you do for the rest of your career. And sometimes when I do a scan particular time, I do require a repeat scan. It can be by chance that it did not happen to be mid-cycle, so I call her a mid-cycle scan. Maybe we did not make arrangements. She's a walk-in patient. I'll call her again for a contrast scan. Maybe the 3D is not available to me in the clinic that I'm working. There are different countries I go to train doctors. I don't have 3D access. So somehow we organize 3D or MRI. Or with this ultrasound completion, I reach a point. This lady needs see and treat, or see or treat hysteroscopy, or she needs a complex laparoscopy with a level 3 laparoscopic surgeon. She needs a complex hysteroscopic surgery with a level 3 hysteroscopic surgeon, or she might need second opinion from gastroenterologist before we do anything. She may have other pathologies that will warrant other referrals. Or you may reach a point, this patient cannot start IUI or ovulation induction or IVF or embryo transfer or allowed to fall pregnant for a recurrent miscarriage without surgical or medical intervention before attempting to fall pregnant naturally or through assisted conception. So this is the level of confidence you should have after you finish your ultrasound in ART or infertility. This is doable. This form was designed in 2008 in London Women's Clinic, Harley Street, London, 113 Harley Street, London. Since then, I think it's my 10th version, because a lot of things keep on updating. I keep on adding things. So that's the purpose of doing an ultrasound scan. Obviously, when you do hands-on training, you'll be filling this form with me. You'll become good at it. It's easy to learn. Do 100 ultrasound scans with me in general gynecology and ART and urogynecology and early pregnancy and fetal medicine. You will get there. Not that I know everything, but there are better people than me from whom I learn. But then I'm desperate to clone myself to pass on my skill to each one of you. and much more. In the same report, you're writing an LMP. Without LMP, without history taking, never touch a patient, never put a probe inside the vagina. Without taking history, why the hell are you scanning? You know, many people are jumping to scan because they're scanning 20 people and they have 10 egg collections and they're traveling all over the world to do egg collections to become super busy. That's not the point. Each patient is your own family member. Each patient is your own soul, that you treat everyone the way you treat yourself or your family member. So it must be, ultrasound findings should be linked to the stage of the menstrual cycle, because cyclical changes need to be documented. Today itself, I received a second opinion call after an ectopic management of letrozole-induced ovulation induction timed intercourse case. She received methotrexate and beta-hCG came down. Because she was irregular spotting here and there, I did ask her to get assessment, but I was told for her to take difestone. And her endometrial thickness is 4 millimeter. And this is from an IVF clinic. I'm sure you all recognize we are so insensitive to science of endocrinology. If there is no endometrium, how will progesterone will ever work to induce bleeding? What she needs is, if the baseline estradiol, her estradiol is less than 50, therefore there is no endometrium, and she wants to conceive, you can go ahead with the next cycle of assisted conception by just understanding how endometrium is thin. Previously, she was normal. It was not damaged. She did not have DNC. So I'm just saying, just now, while I'm preparing this also, today, this is the case. It's very common. Every patient gets difestone for withdrawal bleeding because it's the easiest thing is to pick up a pen and throw a prescription at a patient. Without endometrium, progesterone will not work. Without estrogen, endometrium doesn't come. If it is latex allergy, I'm not sure how many people saw latex anaphylaxis. It's criminal in UK, where I practiced medicine since 92, not to ask latex allergy. If one case of anaphylaxis, you will be out of General Medical Council registry in UK. If there is pain or discomfort or both, you need to take subjective and objective scoring system. You must commit. There is no conclusive findings in PID, endometriosis, fibroid with endometriosis, structural anomalies with acquired pathologies. There are many, many reasons where you cannot have conclusive findings. Be honest to admit that you can't use ultrasound findings to manage, to diagnose the patient or to treat the patient or preventive treatment failure. So in the axis, if the uterus is dextro-rotated, levo-rotated, you cannot see the cervicouterine canal as soon as you put probe in the vagina in the center, as soon as you go to scan. And that should hint you that you need to rotate the probe to correct the dextro-rotation, levo-rotation. You need to assess the cervix first in one particular axis and to turn to another axis to see the endometrial outline, because there is right or left flexion of the uterus. So rotation, dextro-rotation, levo-rotation needs correction. Lateral flexion, right or left, needs particular adjustment of the probe to see the cervicouterine canal axis two independently. If they are in the center, you can see. When you put the probe in the center, you don't see the uterus as soon as you put in the vagina, which means there must be pelvic adhesions. Either it's pushed away from center to the left, or it's pulled towards the ipsilateral side. So the pelvic inflammation, pelvic adhesions can be predicted with ultrasound. Then you can decide to do laparoscope or do vaginal examination. Please don't discontinue doing vaginal examination. In UK, it's a fashion now. Nobody does vaginal examination in ART. It's a fashion. It's a dangerous fashion. So myometrial pathologies, I'll just give an example of adenomyosis, focal or extensive. Give an example of fibroids. Similarly, the shape, cervicouterine canal, just give an example. Polyp, fibroid, scar, endometrium. I'll show the examples of how do we classify early proliferative A, B, C, D category, and relevance of the pathologies: left ovary, adnexe, right, left, hydrosalpinx, right, left, Orcho-Douglas, Dopplers. Then overall opinion, is she going to be a hyper responder, poor responder, normal responder? If there is vasoconstriction in the uterine artery, to what level you will do it? And if you expect endometrium is thinner than it should be, and you think there is basal endometrium, only then you play with endometrial PRP or endometrial stem cells. and same applies to ovary also. So while you're scanning, you see cervix in one plane, endometrium in another plane, which means it is rotated. That's why I showed that video clip. You can see here, endometrium I can see, but cervical canal I can't. Cervical canal I can see the endometrial outline. And if the endometrial cervico-endometrial canal looks like an S shape, that is one of the diagnostic criteria of the adenomyosis. If you are following the guidelines, see the information, the knowledge is aplenty. It's like a cancer. There are millions of YouTube videos, some of them better than my PowerPoint presentation or webinar today, you can learn from. But you need to have the focused learning model, which you can implement with a good equipment, good auditing of your own data to improve on diagnostic accuracy. When you see uterine myometrium, you think of adenomyosis, leiomyoma, iatrogenic causes, scarring, previous myomectomy, previous adenomyomectomy, whatever it is, previous suturing, or a combination of all of them. So that's your myometrial outline. As you can see, we need to follow the international qualification of adenomyosis. By the way, adenomyosis is the commonest reason for T-shape anomaly in the modern days. Previously, it used to be diethyl-stilbestrol usage. You can see the T-shape anomaly. There are still some people rely on MRI, but this is how the adenomyosis, even in 2D, you can see very clearly. And that's the commonest reason for T-shape anomaly. Mind you, I just need to comment on everything because I'm not an ultrasonographer, I'm a clinician. So you can see that a lot of people have a habit of doing lateral metroplasty to create a V-shaped uterine cavity. I understand the logic behind that, but you're not removing the cause, what caused the T-shape anomaly in the first place. That is adenomyosis. Adenomyosis is an autoimmune condition. If you do endometrial immune profile or decidualization score, if anyone interested, just WhatsApp me. I will send entire references, how I managed 20 miscarriages, 20 implantation failure, as good as any top 5 centers in the world by doing the detailed assessment. So even if you anatomically recreate a space, you are not creating implantation-friendly endometrium there. Second, any heat-related burning of this area, it will create endometrial sclerosis. So I want people, anybody doing uterine cavity expansion surgeries, recheck in the luteal phase. Once again, you achieved healthy endometrium where you made a cut, number one. Make it a point. 50% of these people with adenomyosis have depressed uterine natural killer cell activity. That is called endometrial immune profile until 2 years ago. Now it's called decidualization score. This is been recorded. I'm assuming the organizers, please record if you haven't done this already so that delegates who want to just understand how to manage ultrasound findings in the clinical relevance, they will have the advantage.
Yes, sir, we are recording it.
Yes, thank you. So just, making room is not an issue. Implantation is the issue. So whatever people claim that they are greatest hysteroscopic surgeons, they need to recreate implantation-friendly endometrium rather than operation successful, patient died or embryo died or implantation never took place. Again, in the typical 2D world, most of the people are using only 2D. If you do axial view, you will see two little eyes here, which is right endometrial cavity, left endometrial cavity in the transverse view of the fundus. You can see the same here and here also. But if you have a 3D axis here, as you can see how nicely you can see, you only seeing two horns. If you're cutting, making a transverse view here, you can see those two separated. And people jump saying it's bicornuate uterus, it's septate uterus, all the drama, or go for MRI. But if we had a 3D, it goes anterior-posterior view. It's like AP view of the chest or PA view of the chest. So it is not actually bicornuate uterus or septate uterus. There is fundal adenomyosis, which was indenting the fundal myometrium, giving this crescent shape. That's it. That's all you need to know. But that it takes again 20 seconds for 3D to show you. Otherwise, it's complex. Send for MRI, it's very expensive. You need an MRI expert, but all MRI experts are not gynecologists. They can say, they can call this anything. They can call it subseptum. Then you go to cut this septum. You can't cut myometrial indentation secondary to adenomyosis. you won't recreate any healthy environment there. It's already hypertrophic, a lot of scar tissues there. You will not gain anything. You can just make her bleed, sinuses of bleeding tunnels that you will create. Again, myoma, you should follow the international qualification, type 0, type 1, type 2. If you have a MyoSure system, that's the best because it has a no thermal damage and it just involves training. There are many hysteroscopy training centers in most part of the world, largely in India. I understand that there are some limitations in some parts. Based on type 0, you can just chop off without causing any endometrial scarring. Type 1, yes, minimum endometrial damage, but from type 2 onwards, 3 and 4, you're risking, you need a laparoscopy guidance. So if the endometrium covering the fibroid is healthy, many Africans have this, almost 60% of Afro-Caribbeans have fibroids. Their fertility is no less, their miscarriage is no higher. And the key thing is endometrium superficialis is what is needed for the embryo to implant. If the endometrium covering the type 2 myoma is very healthy, embryo can still implant and gradually it will creep. I'm sure you all understand. Placenta can spread wherever there is a healthy endometrium. It doesn't need to get stuck where there is no support. Nature is more powerful than what you and me can think of. I've seen fetal head size fibroids at cesarean section in India, in Delhi, when I was in All India Institute. So I'm not fond of just jumping every fibroid. In infertility, you chop them off and create endometrial sclerosis. Every lesion, you always blame that is the cause. But if you're going to not show the cause-effect relationship with high degree of evidence, and also the benefit of your intervention, improving the implantation-friendly endometrium, you're just gambling with the patient's body, and that's not on. If you see myoma, what is the role of ultrasound? If you see AP view, you think it is superimposing. If you have the superior-inferior view, you can see it is not indenting the cavity. This is the limitation of the so-called 2D ultrasound reports worldwide. They'll say it is impinging on endometrium. Then you go put a hysteroscope and you can't find it. Then the hysteroscopist said there is a joker who is doing ultrasounds. Vice versa. People say the same to the other person also. So you need to know, if you have a 360-degree axis, you know which myometrial pathologies are affecting endometrium by doing hysteroscopy. And if you can create a better endometrium by removing the pathology, do so without charging all the money to the patient, and she won't have money for IVF after that. No, we need to understand, we need to generate a context-based protocol. Not every pathology you see that you are a surgeon, you have a hysteroscope, you have a laparoscope, and you attended a course, you keep chopping people. Here, this case, if you see carefully, we will find it can be an ectopic, it can be kind of, miscarriage. You can call anything. Here also in the AP view of the 3D, you think there is it is within the endometrial cavity. It's behind the endometrial cavity. You see now, endometrium somewhere else, myometrial pathology. There is intramural myoma, there is a calcified myoma, and endometrium is separate from that. And in this 3D, I should be able to show that. So now it is the, some three-dimensional view, and there is intramural pathology. It looks like large part floating in the endometrial cavity, but that's not actually floating in the endometrial cavity. It is in the myometrium. 20% of the myoma was, encroaching the endometrial cavity. And so by rendering patiently sitting, giving the pros and cons, risks and complications, extent of the myometrial damage, expertise that you have, you need to take all the factors before you try to see the amount of invasion of the endometrium that myometrial pathology is doing. So 3D is one of the useful technique of which myometrial pathologist needs removing after hysteroscopy. And after your myometrial surgery, you must establish implantation-friendly endometrium in the place where you remove the pathology. Until then, we are making mockery of which fibroid to remove, which adenomyoma to remove, through remove hysteroscope, through the laparoscope. I heard all these stories for the last 30 years. I'm from institutions. I understand. Unless you show surgery has actually made a better implantation-friendly endometrium in the luteal phase hysteroscopy, I cannot agree with anybody. It becomes very subjective medical practice. Now, this is another case which was referred to me, whether they should myomectomy. I simply said to them after doing the 3D, leave alone that myoma, collect the eggs, because she also had hydrosalpinx, preserve the oocytes, preserve the embryos before you play with any myometrial pathology or tubal pathology or adnexal pathology. You might be able to see there is endometrial cavity. It's one of the oldest 3D machines I've ever used. I don't remember which year I took it. So I just went to the left lateral view. I'm in the anterior posterior view. You can see a rough outline of the white outline of the endometrial chamber. And you can see the calcified fibroid in the left lateral wall of the myometrium. So we can tilt. It's like taking a baby doll. When you're practicing forceps delivery on a baby, you can turn the head into ROT, LOT, OT, OP, whatever you want to play. And 3D is nothing but you can go 360 degrees around your child and you can take any angle of the picture. Therefore, you get a better diagnosis. As I mentioned before, this fibroid simply will say, oh no, embryo will implant in the fundus. This is a calcified fibroid, and so this must be removed. Fibroid is behind the endometrial chamber. You just get that false impression. I do abdominal scan as a complementary. Never underestimate any pathology that is too far from your tip of your vaginal probe. You must take advantage of the abdominal scan or rectal scan, whichever you reach the tip of the probe to the region of interest. Shape problems, as already discussed with you, this was my transverse view with a 2D. When the endometrium looks like eye shape, it looks like a pupil, even at the fundus, that is unicoordinate uterus. If it is split, it can be bicoordinate or septate. You don't know that without MRI. If it is split so widely and you have bowel loops in the center, that is a proper uterine diadelphus. There are huge variations in the normal endometrium. Please don't jump and give a label. Try to force a natural variation of endometrial chamber into that. The only reason I'm showing this slide is you can see the caesarean scar here. You can see the myometrial outline. You can see the endometrial outline. You can see the lateral extensions of the endometrium. That's what the purpose of showing this slide. And you can see the T-shaped anomaly in the making. Just a couple of examples on how a normal endometrial chamber looks like in a 3D ultrasound. This is the anterior posterior view of the uterus. And that is the right sagittal view. The probe is only taking axial view and sagittal view, but it's computing to AP view. That's all. And that's, you can see the left lateral view. That's your typical endometrial thickness measurement plane. And this again, on this side I'm playing, you can see the endometrial cavity almost looks like you're putting a hysteroscope. It looks like to me, I've taken, Alana Institute, we are crazy. We used to do total abdominal hysterectomy and bilateral salpingo-oophorectomy. As residents in AIIMS, we used to fix the tubes to do tuboplasty under operating microscope. All sorts of crazy things, because residents are supposed to be working in the OT until professor leaves the OT. So we did not have chance to do any big surgeries, but we were doing all this. So I remember hysterectomy specimens in my hand looking like this. So this is the level of 2016 software on Mindray Resona 7, right? And if you see 2024 technology of any machine, it doesn't matter which company, the sound conversion into visual is phenomenal stage it has reached. You are seeing the entire endometrial cavity, endometrial outline, myometrial outline to such details as though you're doing a hysteroscopy or an MRI. investing, at least out of 100 machines and 100 gynecologists in any geographical area you are, one should be the high-end machine, no question, because patients should not be compromised by doctors who are much better off than patients financially. We have responsibility to apply technology to our patients. So you don't need any rocket science. You turn any way you want, anterior, posterior view, right lateral, left lateral view. The endometrial chamber looks like a finger, eye shape. That is unicornate uterus. You can see the septate, complete septum, and you can see adenomyosis distorting in a funny way. You don't need to give names to anything. You can say unspecified shape. That's what I'm trying to say. This lady had a stillbirth for which she had a cesarean section. And she came for as a volunteer for one of my ultrasound hands-on training workshop. So as you can see in a longitudinal scan here, typically you're just doing a 2D. We have a habit. We just put the probe, we see endometrium. There is a beautiful endometrium, and we are done. Take the endometrial thickness, you see for the ovary and gone. If you rotate the probe in the transverse view, you saw 2 endometrial cavities. You didn't know septum or not, or bicoordinate. Then you put the 3D, so you begin to see some more details. And you can always, sometimes, accidentally you will get 2 horns also coming in the view. But typically, if you're having a good 3D ultrasound AP view, you can see septum, cesarean scar from before. So I can't explain why she had a stillbirth, but obviously the placenta accreta features are much higher if the implantation takes place on the septum, which doesn't have a beautiful myometrial endometrial epigenetics. Again, endometrial cavity can be a wide V shape in a multiparous. You can see the 2 uterine arteries here. It can be a bit cylindrical or it can be T-shaped. When you do septolysis, sometimes it's not always possible to remove the whole septum. You can do in 2 stages. You can bring the complete septum to large subseptum and then subseptum, small septum. And as long as the implantation doesn't take place on the scarred sclerotic area secondary to your diathermy surgery, she will get away and she'll be very thankful to you. Cervical canal, you can always see cervical canal polyps, cervical canal mucosa, all that. It's part of the general discussion. I'll be doing it. By just putting a saline or a distilled water or an exam gel without air, occluding it so that it doesn't leak through the external os, you can see the endometrial cavity to these details. This is called contrast scan. Saline or gel, distilled water, it doesn't matter what you use. Some people, for gynecology, they use lignocaine gel because, most of us are innovative. This is again a glass view, we call them, of the endometrial chamber. So this is the left sagittal view. Without my knowledge, I went to the posterior anterior view, so I was not in the right plane. So then I just rotated XYZ planes. There are a few knobs you play called rendering. This is like rotating it, This is the AP view I'm doing. Previously, I'm trying to go on the back. Now I went to the front. So as you can see, myometrial outline, endometrial outline, the thickness of the endometrium, nothing in the endometrial cavity. 20 seconds, machine does it. 3D is a machine skill, not your skill. Sometimes you see in the uterine cavity, air. Sometimes you see coil embedded and so on. Sometimes you can see fetal bones. It doesn't matter. My old 3D, I used to rely heavily on GIS. It was just showing a little bit of space occupying lesion like an HSG. But by putting a saline, as you can see, and taking a correct plane, you know how much myoma you can resect with your resectoscope. So you must liberally use gel or saline infusion scan prior to hysteroscopic surgery, even if you're not doing ART, even for gynecological practice. Let's say we are focusing on endometrium. So I want the organizer to remind me, because the total duration is 2 hours. I've already taken 40 minutes, not 40. I think I've taken 30. So maybe towards the end of 1 hour, in 20 minutes, then people can have a glass of water or drink, and then Dr. Meenal can do. Is that okay?
Absolutely, doctor. We'll do that.
Yeah, I'll just put some light. Just give me a second. So when you assess endometrium, you must be aware of endometrial waves that gives the false positive, false negative, abnormal measurement of endometrium. You must see its continuous echo or interrupted echo. You must see its homogeneous or heterogeneous. You must see it as early proliferative, late proliferative, early luteal, late luteal. It is called ABCD grading. This is only histology-based classification in the world that I introduced in Bone Hall, Cambridge in 2003. Then if it is thickness, you must say it is normal thickness, but inhomogeneous, thin for the stage of the cycle, for the level of hormones you have given, thick for the level of the stage of the cycle, for the dose of the hormones and duration of the hormones you have given. So it is expected thickness or unexpected thickness, expected thinness or unexpected thinness. I'm very particular about this because when I implanted on my mother, I only implanted on 4 millimeter endometrium. I repeat, when I implanted on my mother as a hatching blastocyst, I only needed 4 millimeter endometrium to implant. I don't need 8 millimeters. So I want to clarify this issue to everybody who is listening to me today. Only on hysteroscopy, you'll know where there is 4 millimeter endometrium is available. It's together, 4 plus 4 is 8. And no placenta will implant here and here. So, and then you worked out the thinness and thickness. Then you look for focal lesions, one polyp or polypoidal endometrium. Yes, no, doubtful. Focal lesion, scar. How does scar look like? It looks bright, and behind the brightness, there is a fallout area. Then you say, yes, I suspect. Sorry, yes, I know it's a scar. No, it's not a scar. I'm doubtful whether it is yes or no. I don't know. For every condition, you must spend time. That's why I explained to all of you that you must use this sheet that I'm sharing with you, with all of you. And it's in my, the book, handbook on, you must use this. You can put your own hospital logo. I don't mind. There's no patency for that. This is grade A, grade B, grade C, grade D, based on the histology, hysteroscopy, and everything. All right. So A means estrogen is around 50 to 100 picogram. B grade means it's up to 300 to 500 picogram. C means progesterone is added on the top of that up to, let's say, 20. Premenstrual, when endometrium is undergoing ischemic necrosis, which means estrogen corpus luteum is about to die, estrogen is dropping, so there is induration that happens to the endometrium, that is D-grade endometrium. And each one can be homogeneous or heterogeneous. If it is heterogeneous, you must do saline scan or hysteroscopy. This is endometrial waves. Maybe some of you know this, you saw it before. It's nothing but myometrial contractions, but seen as endometrial junctional zone contractions. This is nothing but labor pains. This is nothing but Braxton Hicks contractions. This is nothing but menstrual contractions. There are fundocervical, one type of contraction, cervicofundal that happens to facilitate the sperm to be sucked into the fallopian tube. And the third one is circumferential contractions. That happens for expansion of the uterus when the pregnancy is there. Okay, fundocervical, cervicofundal, circumferential. And you can see them if you are careful. So I'll just do fast forwarding. You will see the endometrium. It looks homogeneous, non-homogeneous, like a wormy, like a little worm swirling, like a whirlpool. You see there is 2 polyps here. No, that's rubbish, just an endometrial contraction. But if you take a static view, you will say, no, endometrium doesn't look good. But you have patients, that wave will show better endometrium. You lose no trilaminar endometrium. You say that there is a polyp right now. I'm showing everything live to you. This is called a normal endometrial wave. I did a hysteroscopy for her. She doesn't have any polyp. But that's unnecessary surgery, unnecessary blaming of implantation failure. So this is a peristalsis of endometrium. You can call junctional zone contractions or rehearsal pains for labor pains. All right. So I'll do fast forwarding. You will see very funny look. Can you see? It almost looks like a snake. I can play this one. Can you all see? So I can diagnose 6 polyps there. There's no polyp, just the endometrial waves. All right. So we discussed polypoidal endometrium. What is the treatment for polypoidal endometrium? And how reliable is ultrasound? If you resect this, she will grow again after 3 months because hyperestrogenic state is not being sorted. So please don't do quick fixes, symptomatic treatments. You address the pathology, not the symptoms. So I gave 𝗀𝗏 analog 12 weeks, up to 12 weeks in some cases, 9 months sometimes, typically 6 months, minimum is 12 weeks, 11.25 milligram 𝗀𝗏 analog. If for whatever reason you don't have it, you can give dydrogestrone or any progesterone day 5 to day 25 for 3 to 6 cycles and recheck what happens to the polypoidal endometrium. I can show hysteroscopic evidence. In vast majority, it will cure it. What is the correlation between hysteroscopy? As I said before, I have a separate presentation. The correlation between ultrasound, contrast ultrasound, and hysteroscopy, I have the world's second largest data, including histology. A beautiful luteal phase endometrium, I expected hysteroscopy like this, but she had 3 pathologies, which means if I claim that by using ultrasound alone, I will get 70 to 90% pregnancy rate in my clinic, I'm bluffing to myself. Self-dishonesty is the worst crime you can ever do. We call them haram in this part of the world. So it's a crime to give false illusion to the patients that you have done everything and God only knows why she's not getting pregnant. Your ultrasound is useless in half the times. Hysteroscopy expected in luteal phase from this is this, but instead I saw hypertrophic endometrium, atrophic endometrium, endometrial varicose veins. I'm the same person doing luteal phase hysteroscopy in the same sitting without anesthesia. So I don't trust my ultrasound finding. I do universal hysteroscopy. In the mid-cycle, after giving 12 milligram of estrogen, or there are 10 follicles, you did egg collection. On the day of egg collection with high dose of estrogen, you see this endometrium. This is a case of endometrial sclerosis. She needs surrogacy. Sometimes you don't see trilaminar, you see edema. There is darkness in the center. There is no trilaminar. You do hysteroscopy. Anterior endometrial wall is edematous. Posterior wall doesn't look. They don't look at the same lady. I'm talking about anterior wall of uterus, posterior wall. This is a classic polycystic ovary thick endometrium without polypoidal changes. Some do have. When you see one polyp, don't assume there is only one polyp. When you measure the polyp on 2D, more often than not, you're inaccurate in its measurement, in its base, and so on. If at all you're going to do polypectomy, I know it's not a hysteroscopy lecture, but don't do blind polypectomy. This is what you end up. So I do hysteroscopy after so-called people doing polypectomy DNC. I put the scope and show them how miserable a DNC as a procedure in infertility practice is. Not only that you can't remove the polyp, you just induce endometrial sclerosis. And the polyp will grow because you didn't remove. So just because you don't learn hysteroscope, you don't invest in hysteroscope, we are still doing mockery of care in many, many infertility clinics. Pathological. Doctors are pathological. So this is just a saline scan. One of my nurses was, we just put any Foley's catheter and put the saline without air after priming. You can see a polyp. You can see sometimes in a 2D scan base of the polyp. Whether you have a vessel or not, you must remove them anyway. So vessel or no vessel, you must remove. And this is the anterior posterior view of the 3-dimensional contrast scan. Contrast is saline. You can see uneven elevation on the posterior endometrium. But that is the AP view. I want to see my own face here to show you whatever. So that is the AP view. Now I turned it this way because if there is a pathology on the elevated polypoidal posterior endometrium, you need to turn the uterus to sagittal plane within the 3D to see the uneven thickening of the posterior endometrium. So what do you do with focal endometrial hypertrophy? What do you do? By just shaving it off, it's possible the healthy endometrium might grow, or you might cause permanent bald head because you used heat that damaged the endometrium and caused endometrial sclerosis. Then what will happen? At least you can put embryo in the left quadrant. by using a Cook catheter, directing the embryo to the left quadrant under ultrasound guidance. So that's called endometrial mapping. So for every slide I'm sharing with ultrasound lecture, I'm giving you clinical relevance to it. And by the way, I have a hysteroscopy template, which is very exhaustive. Anybody interested? It's in the handbook of ART that anybody can share. In this slide, I'm just showing one thing. As you can see, this is an 𝗪 there is cervical mucus, and this mucus sometimes gets sucked into the endometrial cavity. So I have 17 cases audit on endometrial cavity fluid, how it affects ART. Either you remove it in the proliferative phase, you might get away, but you need to do TVS at the time of embryo transfer. Even if there is the thinnest film of endometrial cavity fluid, never transfer the embryo, because you're putting a cling film between endometrium and the embryo. So you cannot expect implantation. That's what you need to approach. So I always keep an ultrasound. Even before embryo transfer, I do TVS. When I have a difficulty or my colleague having difficulty, they call me, always do TVS, always do vaginal examination. And then try if I can do an easy embryo transfer after that. When you see polyp in 3D, you have an advantage to measure whether it is easy to do hysteroscopic polypectomy or not. Also, whether it is just a tip of the iceberg, which means polypoidal endometrium is in the making. You can see the variable thickness of endometrium that I measured. So even if we remove this one, if there is a gap of 3 months, you will find another 2-3 unwanted guests popping like pimples. It's almost I call pimples in PCO. I showed this slide before. This is called, you can see the pinching of endometrium into the myometrium. So this is adenomyosis. I'm moving slowly into myometrium adenomyosis. As you can see in the AP view, you won't get a good view. In the right sagittal view, you can see endometrium growing into the myometrium. And you can see subendometrial polypoidal changes. It can be just adenomyotic focus. This is just a 3D of left sagittal view, and you will see how the endometrial polyp appears. This is the left lateral view. Now I'm turning the probe into the front of the uterus, and then you can zoom in and out. You can see, and now I'm doing to the right sagittal view. You're just playing the buttons. Then you tilt the uterus forward to get the superior inferior view. This is the inferior superior view. I'll just go to, just to speed up. So that is the superior inferior view with the polyp distribution very clearly. It's from the posterior endometrium, and you can see the width of the polyp lesion. This case came for an egg collection. Known PCO, tubes, patent, sperm is normal, unexplained infertility with PCO, ovulatory PCO. When I was doing egg collection, I found endometrium was non-homogeneous. I put embryo culture fluid. This is way back in 2003 in Cambridge Bone Home. I wasn't too happy with the polypoidal nature of endometrium, but the patient refused to do any intervention. She wanted to proceed with embryo transfer. And the reason for that is she underwent polypectomy by one of the best endoscopic surgeons in Europe, in Turkey, 7 months before I met her. So that's the history. So she said, yes, I had polyps. It's been removed. So therefore proceed with embryo transfer. Obviously it didn't work. So she came back to me. Then I did the repeat hysteroscopy. So can you believe this is the repeat hysteroscopy after approximately 9 months of doing hysteroscopic polypectomy, removal of 9 polyps. So polypoidal endometrium treatment with knife is not successful. Polyp is different from polypoidal endometrium. Polyp is one-off pathology, and you remove them, very rarely they come back. Polypoidal endometrium is a hypertrophic, hypermetabolic state of hyperestrogenic, non-progesterone environment. So you must deal with that separately. Let's say you're going to ovary. So in about 6 minutes, I'll just finish the ovary, then Dr. Meenal can take the lecture. So you must know present or absent of the ovary, visibility, clear or poor, variable visibility. Access is good for egg collection or there are blood vessels between ovary and 𝗈. Need to do abdominal collection. Antral follicle count, pathetically inconsistent. I see it regularly. People say 5 follicle, they collect 15 eggs. When they write 15 follicle, they go back and collect 5 eggs. There are many reasons why lack of correlation. But I want you to, each one of you, to audit next 100 cases. What is your baseline antral follicle count? What is the M2 oocytes you get? Otherwise, you will never improve. So self-audit is the only way. That is spirituality. Self-audit is spirituality. So volume, obviously less than 3, reduces the response. PCO, separate lecture on its own, but I'll share a couple of points on PCO aspect to it. So if the ovary, no sliding sign, there's no sliding, you know you're going to have problems either to access myometrial trauma, endometrial hematoma, pelvic hematoma, post-operative pain, less eggs being collected because your needle tip is not visible. You have to go through subserous fibroids sometimes, intramural fibroids sometimes. You don't even know it's hydrosalpinx sometimes because they all look same. So to prevent complications, you use ultrasound very diligently. You highlight it in the ultrasound scan report because somebody else may be doing a collection, not you. So they are alarmed. They are forewarned. So it's very scary sometimes when I don't even see what this structure is. There is ovary, there are 2 follicles, there is a cystic collection, and there is something which is avascular structure. I can always say whatever theoretically I can write. So please, these are the cases. You must do laparoscopy. And again, you need to be an expert in laparoscopy. Going, seeing, just giving a, kissing just structures by tapping them and, tapping them on their face. A lot of laparoscopic surgeons are not good. They just go, they do something what they are not scared of, and then they get out. So you must know, why do you need to laparoscopy? When there is inconclusive adnexal pathologies, that's when you take the route and use your better colleague, because there are greatest surgeons in every country, but you must to learn from them. Okay. So sometimes, you can't access ovaries. I'm sure you all know how to measure the antral follicles, but you need to go plane by plane. This is audit I've done in London Women's Clinic. There is no good correlation between my radiographer's ultrasound finding and the number of follicles we are tapping, both in the overestimation of the follicle and underestimation. Both are extremely common, which means the specificity, which means your ability to get the outcome that you required, is not consistent unless you audit your own. Somebody is scanning, another body is scanning, another person is doing a collection. You must audit your own. You should know how the normal variations of the ovary look like. This is a spontaneous ovarian hyperstillation syndrome. In a natural pregnancy, I saw. That's why I just put it there, because the HCG of the baby or the placenta can cause hyperstimulation in very hypersensitive ovaries. This is the cumulus oocyte complex. This is the cribriform form of corpus luteal hematoma. This is organizing corpus luteal hematoma. So you need to know what is the normal finding, and you need to know what to expect in a low antral follicle count, free fluid, corpus luteum. There is a bowel sitting next to it, and this ovary is dancing around. You can always see ring of fire. All these things are something that, you just make it a habit to keep on writing all these findings and discussing with it. This is the left adnexa, which was different. PCO, lack of slow pulsatility of GnRH causes dominant LH secretion from pituitary that stops the steroid pathway at 19 steroids. From 21 to 19, they stop, they don't go to 18. That is the pathology of PCO, which means large number of follicles remain instead of being shortlisted to 1 follicle. So 60 applicants, 20 for the interview, 1 gets the job. That is typical normal ovulation. Whereas here, 60 applicants, 60 come for the interview, nobody gets the job because nobody performs. It's like I sell too many girls, nobody want to get married. And the endometrium, because it's never groomed, it looks non-homogeneous. You must always do hysteroscopy in every PCO. You'll find sometimes cancer also, endometrial hyperplasia, calcification, all sorts of things. Sometimes hydrosalpinx looks like follicle. I've seen people putting needles into this. Sometimes the transverse section of internal iliac vein also, people put needle to collect because they're taking the axial view of the internal iliac vein. Not rare. we have 2 cases in the last 6 months, medical legal case I manage here. You don't need 3D, sonovac, all that to measure the, I say more than 15 follicle, finished. I don't need to write there are 40 follicles, 42, 35. I don't need to. Different age of the corpus luteal hematoma will show different findings. So that's where I will stop for ovary now. I will take endometriosis afterwards. So Dr. Meenal will go through the book chapter extract, which was meant to be how diligently to use ultrasound in assessing ovulation induction or controlled ovarian stimulation and controlled ovarian hyperstimulation. I'm sure you all understand the 3 words. Yes, Dr. Meenal, I'll stop sharing the organizers to assist. Thank you. It's an hour or just under an hour I've been. Thank you.
Yeah, sir. I think your presentation was fantastic. We'll take another 2 minutes to 3 minutes to have the technology talk, and then I will introduce ma'am and hand over to her.
Go ahead, please. Thank you.
Yeah, just a second. Let me switch on the presentation. So, okay. So again, this is like, sir has shown such a beautiful images from his presentation and from our equipment, that is 𝗎𝗓𝗓𝗍. So it's very proud moment for me to introduce 𝗎𝗓𝗓𝗍 Elite Edition, which is our flagship model powered by ZST Plus technology, focusing on the women's imaging segment. As it is powered by ZST Plus technology, it's 2 generations ahead than the traditional beamformer, and which enables the clinicians to perform diagnosis more effectively and efficiently. So this actually focuses on all the applications related to women's imaging, starting from giving infertility solutions, where we have endometrium receptivity analysis tool, we have ovarian tumor analysis tool, we have follicle monitoring analysis tool, as well as we have the 3D/4D we have the shear wave elastography also in the gynecology segment. And we have the complete solution for, of course, for the pregnancy and for the postpartum. So this machine is having a wonderful 2 endocavity probes, which is V11-3H, which is high density probe, and another is D10-3WS, which is wide angle probe, which gives you beautiful resolution that we already saw from sir's presentation, and it gives you great penetration for all the high BMI cases. So this also enables us to have the another wonderful tool called as 𝗍𝗨𝗍. So when we introduce this 𝗍𝗨𝗍, it introduces the light source inside the uterus to see all the pelvic structural abnormalities more intuitively. So that's about all these wonderful images that I'm showcasing. And over and above that, for having the pelvic blood flow perfusion, we have the high resolution blood flow, high resolution color flow. Along with that, when we combine it with the glazing flow, this gives more 3D effect, and it also gives you all this tiniest vessels, and it also gives you the 3D visualization of the color, all the vessels. And apart from that, when we have to see the tiniest flow like endometrium flow or the ovarian flow, all such kind of flows, we need to see the radial arteries, spiral arteries, or the arcuate arteries. We need to have the very microvascular flow. So for that, we have the ultra micro angiography, which is again the real-time color imaging technique for all the microvascular flows. So when we are talking about the uterine evaluation, it is very necessary that we do all the 3D/4D scans. Of course, it's an essential tool. So for that, we have the volume evaluation tool called as SmartScene 3D in the endometrium scenario. And over and above that, we have the Smart ERA also, which is endometrium receptivity analysis. So all you need to do is just press SmartScene 3D while taking the uterus, it will automatically recognize the endometrium scenario. It will do all the ROI adjustment for you. It will do the rendering for you, and it will give you the endometrium volume also, along with the endometrium thickness. And it will also, if you have taken the images with the, or taken the volume with the vascular flow, it will give you all the vascularization analysis also, like VI, FI, VFI, all these values you will get to know the better receptivity of uterus, endometrium. So you can see all these images. We have iLive, Hylene, all these techniques will have very good image quality, and it will give you more intuitive results on the 3D 4D scans. Apart from this, when you want to do the follicular monitoring or the follicle scans, ovarian evaluation, we have this tool called as Smart Follicle 3D, and this is an easy and effective tool for the 3D ovarian, reserve evaluation. So all your follicles will be automatically counted, and it will give you the volume. So for all the follicle monitoring, it becomes very easy for this analysis. Apart from this, we have seen a lot of images from Sir's presentation again for the 𝗀𝗳𝗃𝗃. So we have this beautiful tool called as 4D 𝗀𝗃𝗃, which is hysterosalpingography contrast sonography. So this also gives you beautiful images to see the patency of the fallopian tube. So either it is partially blocked or fully blocked, or it is open from both the side. We can do it very nicely with this 4D 𝗀𝗃𝗃 tool. You can see some of the wonderful images scanned on the 𝗀𝗃 machine. These are some of the very advanced technologies from the 3D point of view. All the smart era of smart follicles, shear wave elastography, 𝗀𝗃𝗃𝗃, all these images are there. So I will have a small video, just 2 minutes of video. Please allow me to play that. Okay, the volume is coming. Is the volume coming? Just a second, let me share it again. I'm not able to enable that volume thing. Okay, let me just share the presentation again and hand over to ma'am. I was having a small video. So overall, when we talk about the 𝗀𝗃 i9 machine, okay. Just a second. Yeah, so when we talk about 𝗀𝗃 i9, it gives you the full stack smart solution for the women's imaging, starting from the fertility. Still, I'm having this video only. Yeah, starting from the fertility to obstetric scan, as well as the, just a minute. And gynecology and the urogynecology. So it's an overall solution for the women's imaging. Now I will hand over the stage to Dr. Meenal Chidgupkar. But before that, I would like to introduce her. It is again honored for me to introduce Dr. Meenal Chidgupkar, who is the director of Dr. Chidgupkar Hospital Private Limited and senior infertility and IVF specialist at Apollo Fertility, Solapur. She has done her diploma in fertility and laparoscopy from Kiel University, Germany. She has also completed a lot of fellowship programs, and with over 12 years of expertise in fertility and laparoscopy, and her extensive work in adolescent health, pre-cancer detection, women's health, she is a leader in her field. So please join me to welcome Dr. Meenal Chidgupkar, ma'am. Over to you, ma'am. I will stop sharing. I will share your presentation so that you can start your talk. Just a second. Okay, my slide is seen, right?
Yes.
I will mute myself and I will make it full screen. I will mute myself and
Am I audible?
Yes, ma'am, you are audible. Please, you can go
Okay.
ahead.
Okay. Respected seniors and all delegates, it is an opportunity to present this chapter of monitoring of ovarian stimulation by ultrasound. This I wrote with Dr. Karunarakara sir, and it was a great opportunity for me to write this with him because it was a great learning experience to write this chapter. Sir has wonderfully already explained the everything regarding IVF and ultrasonography. I am just trying to brief certain points which are important in the monitoring of ovarian stimulation by ultrasound. The next slide. Next slide, please. Only that can be measured is quality. Ultrasound is an integral part of the patient care pathway in the diagnosis and the management of infertility. The aim is to detect and reduce the incidence of OHSS, that is ovarian hyperstimulation syndrome, and to achieve optimum ovarian response culminating in a successful singleton pregnancy. Next, 1978, world's first in vitro fertilization baby born in Northwest England, and in the same year, the Hacklior described the ultrasound monitoring of developing Graafian follicles in natural menstrual cycle. In the hands of diligent, well-trained, knowledgeable operators using high-quality equipment, ultrasound screening allows the identification of pelvic pathologies linked to infertility and ART treatment failures. So it is essential to have started the operative procedures and auditable standards in the usage of ultrasound in fertility centers. So it is very important to have the understanding about ultrasound in infertility practices. There are various consultation ultrasound reports which sir has already explained to get information regarding uterus, uterine cavity, endometrium, ovaries, adnexa, Doppler studies, and ovarian reserve. This first consultation ultrasound is very important and it decides the ovarian response, if it is like normal responder, poor responder, or hyper responder. And accordingly, we can plan our further treatments. The next. When there are mild stimulation, the stimulation can work and give, like it can have the quick responders in that, it can have optimal responders, sometimes slow responders and aberrant responders, and accordingly we can plan the ovulation induction and natural intercourse or IUI in mild stimulation protocols. This is the case study of hyperstimulation folliculogram, where the patient, the baseline study, the stimulation days, the follicular size, how it is growing, the details of hormones study, and the response to the stimulation protocol is well explained. And these folliculograms are done by Dr. Karunarakara sir over his expertise for many years and updated these folliculograms, and these will definitely give you the exact understanding of how the stimulation protocol is progressing. The next. As I told you, these above templates are from Dr. Karunarakara sir. Next. Next. The measurement of follicles. The acceptable follicle measurement technique, such as when there are small regular follicles, we can have a single measurement protocols. When there are larger follicles, 2 to 3 measurements and the volume measurements to be taken. Inner to inner positioning of calipers after taking the widest plane of section of follicle. And this diagram, which is shown here, which has like baseline, then stimulation phase, and the volume measurements also. The follicle measurements, the follicle is left and of the right ovaries, A and B measured by the 2D ultrasound, and C and D are measured by the 3D sono AVC. Currently, 2D manual follicular measurement is the gold standard. Next. There are certain erroneous measurements, and these can be because of machine settings, method, operator, and patient dependent. One example is when there is limitation due to the deepest location away from the probe in cases of transabdominal sonography, and the erroneous measurement of antral follicle count and the follicular growth can be observed because of that. Next, it is important with the international guidance of professional ultrasound practice, such as we have to follow 2021 publication by the Society of Radiologists and the British Medical Ultrasound Society. Then AIUM practice parameter for the performance of a focused ultrasound examination in reproductive endocrinology and female infertility, which is 2019 publication, and ISHRE working group on ultrasound in ART, which is 2019, and even the ISWAG website, which gives information about this guidelines regarding ultrasound usage in infertility practices. So whenever everyone all across the world using these parameters to get the progress or understand the infertility and fertility parameters in women, it would be of great importance for even for the patients. And overall generalization and understanding of all these parameters is important when we are practicing ART in all across the world. So collateral ultrasound findings, which are also very important when we are looking for the ultrasound monitoring in ovarian stimulation, because when we are looking at the ovaries, we have to certainly see certain other factors around the ovary and the pelvic area. In addition to measuring follicle, screening and diagnosis of uterine, endometrial, adnexal pelvic pathologies are fundamental component of ART care. Strong junctional zone contractions during stimulation phase are linked to reduced implantation rates, and there are commercially available tocolytics, but with the limited supporting evidence on their benefit. We are not sure about those benefits exactly. Finding of free fluid have clinical implications, therefore must be recorded, monitored, appropriate to the context of the case. Uterine cavity fluid can be a mechanical barrier to embryo implantation, and one of the suggested methods include aspiration of mucus prior to commencement of the luteal support, as exemplified in certain cases illustrated. Next. So the key points after we come across, after understanding this monitoring in ovarian stimulation, are essential methodology and the clinical application of ultrasound during ovarian stimulation is described in 3 distinct stages of treatment cycle as explained, that is the consultation, that pre-treatment, the mild stimulation or hyperstimulation, these ways, the individualized and contextual monitoring schedule is adopted appropriate to the patient and resource setting, folliculogram templates, mild and hyperstimulation protocols, along with suggested monitoring guidance specific to the categories of quick, optimal, slow, and aberrant responders, which are provided. The monitoring scans are continued until majority of follicles are measured over 14 to 16 millimeter, ensuring more than or equal to 3 follicles over 17 or more than or equal to 2 follicles over 18 millimeter in size. Non-responder and very slow responders should be considered for a flexible or individualized ultrasound monitoring schedule. Next. It has been evidence that the mean follicular growth rate is 1.4 millimeter per day in spontaneous menstrual cycle and 1.7 millimeter in the stimulation cycles. This trend is evident in the same case examples where the majority of follicles grow was typical, yet few follicles growing at a variable or the faster or slower rate. 𝗍 guidelines recommends triggering when several of the growing follicles in a particular patient to reach 16 to 22 millimeter in diameter to expect the highest yield of mature oocytes. Next. So tailor-made monitoring plan should be adopted for hyper-responder and aberrant responders, combining with the clinical assessment to avert a risk of severe OHSs. Every fertility center should have explicit local protocol in line with the international governing body guidelines on ART services, including ultrasound, diligent screening, recording, reporting in an integral component of the quality management system in ART practice. Merits and limitations of 2D transvaginal ultrasound, 2D trans-abdominal ultrasound, and 3D ultrasound in acquisition of optimal images during follicular monitoring have to be understood, and this all things are explained in our book chapter comprehensively. Newer technology-based ultrasound machines with better resolution, speedy folliculometry with 3D sono AVC and selective utilization of color Doppler studies can be incorporated to maximize diagnostic accuracy, to improve success rates and reduce complication rates of ART treatments. So these are certain key points of our book chapter, and we wanted you all to read that book chapter, and I want to be brief in presenting because even I want to hear more of Sir's lecture and his point of views on these parameters also. And we definitely have question answer sessions where you can ask questions to us. Sir will answer them, and we'll have a more interactive session ahead. Thank you.
Yeah, thank you, ma'am. So we again hand over the platform to Dr. Karunarakara, sir. Sir, you are there?
Yes, I'm here.
Yeah.
So where I was here. I was planning to talk. Can people hear me? Just to reconfirm that I'm in connection properly.
Yes, sir. We are able to see.
Am I audible? And the screen is endometrioma.
Yeah.
Yeah. So before I go to endometrioma, I just wanted to highlight on this slide that I just transferred from my hysteroscopy lecture. I was talking about myoma, and there are many people who are listening who does myomectomy for infertility. Typically, the luteal phase endometrium, this is the anterior wall, that's the fundus, as you can see. It should be this level. And there are people where you do hysteroscopy, then you may find 3 submucous fibroids, such as this one. you may find a submucous fibroid, which is completely cicatrized, which means scarred, almost like a burns injury, scarring. You may find a submucous fibroid with a surface epithelium, which is vascular congestion, intermenstrual spotting, perimenstrual spotting. She may be a symptomatic submucous fibroid. Or you may come across something like this, which is none other than 𝗀𝗃, who invented endoscopy. If you all know, who knows Professor Lila Mettler, she's the living legend of endoscopy, keyhole. And the boss for her is 𝗀𝗃, German, who is a principal figure behind laparoscopy and hysteroscopy. Not necessarily hysteroscopy, it's a laparoscopy. So he did the multiple myomectomy for this lady, laparoscopy guided. So both laparoscopic, hysteroscopy. This is endometrial sclerosis. If you can see the blood vessels here, they're all horizontal. Each blood vessel here is going horizontal to the endometrial plane. Normal endometrium in the luteal phase, you'll never see blood vessels. You will see the end-on view, but again, it is so distant. You can't even actually make bleeding by just poking with embryo transfer catheter or even a tip of the hysteroscope. You can puncture the tip of endometrium in the luteal phase, still there is no bleeding. But here, if you see, it's almost inflammatory, chronic inflammatory. We call them telangiectasias secondary to surgery. So there is no chance she will have implantation. But she had a successful submucous fibroid resection. This lady, she's African. She got married to an English guy after having had children with an African husband in Africa. She moved to London or England, and then she got married to somebody who got vasectomized. So she came because of the azoospermia secondary to obstruction. So, but when I was doing a collection, again, I had this urge, like any junior doctor will jump and find diagnosis, overdiagnosis, whatever. I said, there are so many submucous fibroids and I'm very good ultrasound. And she said, okay, doctor, I have fibroids, so what? And I want to do hysteroscopy. For whatever reason, she agreed. I did the hysteroscopy. I ran to my medical director, said, there are 3 submucous fibroid. She's not going to implant. And the patient refused, actually. She said, in the entire Africa, most of us have fibroids and we have children. I didn't come to you for my submucous fibroid, nor I have any symptom. I only came because my husband is vasectomized. That's why you're doing IVF. So would you mind, doctor, just do embryo transfer? So I transferred embryo. She got pregnant and I didn't hear from her what happened. Anyway, how do you explain that? The embryo implants to endometrium. Even on a fibroid, there is a healthy endometrial layer, 50% of endometrium, which is the endometrial superficialis. Then comes the parabasalis and then basalis. Embryo doesn't attach to basalis and parabasalis. So as long as there is healthy, uneven elevation also, it's like a golf ground versus football ground or a cricket ground. The grass can grow both on the golf ground, which is uneven, or mountain, grass can grow. Sheep only eats the grass. He doesn't want to know the grass is on the mountain or in the level pitch. That's very simple. So not all submucous fibroid needs to be removed, but this one with scarring, embryo doesn't get any endometrial glands here. This one, obviously, bleeding might happen at the time of embryo transfer. There may be uterine cavity blood. And when you put embryo hates prostaglandin. Embryo doesn't like red blood cells, full stop. So these 2 need to be removed. But when you remove, you must be damn good at it. You never create this endometrium. Unless you're going to create this endometrium, don't even bother doing hysteroscopic surgery. That's why I wanted to just add on, just diagnosing fibroid and ultrasound, jumping around with, different protocols is not what matters. Patient should benefit from your knowledge and skill. So let's talk about endometrioma. This, obviously, you don't need 3D for that. Most of the time you can diagnose, but I wanted to know maybe 30-40% of endometriosis is endometriomas. Everything else is in the pelvis or adenomyosis. You're not treating them by just jumping around discussion of 3 centimeter chocolate cyst. I removed it. Then why is not to get pregnant? You didn't understand the whole spectrum of endometriosis. It is not endometrioma that causes infertility. It's the endometriosis. It is anti-inflammatory. It is autoimmune condition. She may have adenomyosis. Adenomyosis will have decidualization score compromise. Adhesions will have its own issues regarding infertility. So you need to treat the complete set of things, not just one of them. If it is adenomyosis, you will see the endometrium in the axial view will not look horizontal. It will look oblique. This is the normal expected endometrial outline. This is oblique. Even here, this is a low-grade ultrasound 2D picture. You can see the endometrium this is the endometrial outline. It doesn't go horizontal. And you can see there is endometrioma, endometriosis. There's no sliding. There's one follicle here. And one of the diagnostic criteria for adenomyosis is endometrial outline will be S-shaped. Can you see? This is S or 2 shape. One more thing I want to discuss endometriosis is that you may not see the entire spectrum of endometriosis. This is where the laparoscopy will come to play. There are people who has myoma, adenomyoma, plus pelvic adhesions. You may not be able to see ovary as ovary, follicle as follicle. Hydrosalpinx may look like this. So complex adnexal findings are the ones which need you to understand rather than just an intra-ovarian small endometrioma and you just go and remove. There are no nice people. There are no nice cases. Medicine is complex, right? You're lucky just to find 10-20% of cases are very nice. You just do Royal College guidelines, SRM guidelines. You found a diagnosis and you told you what professor told you, did the treatment and she got pregnant. This is very small. Most people have complex pathologies. So you need to have as much diagnostic information, as much senior input before you manage and get the success out of the patient. Sometimes you see ovarian cysts. If you have 3D, there is an advantage. You can accurately estimate all the antral follicle, and you can see it's almost like you're in an aquarium. You can see the antral follicles behind. The point is, 3D, if you have it, it does help to assess any papillary projections within the intraovarian cyst, whether it is, borderline malignancy, papillary, dermoid details, a lot of things you can show, and also you will get the more accurate estimation of the endometriosis, antral follicle count. Or you can see dermoid cyst very clearly. And before I go to this tubal patency test one more time, I just want to open another presentation, which was how endometriosis in 3D currently can make a difference in your management. I asked a lot of people in the different part of the world, can the admin people tell me which screen are you seeing? Can you see unicornate uterus here? Hello?
No, sir. It's
You
the
can't?
same.
Okay. No, I want to unicornate uterus to see, so I'll just change sharing screen. Yeah. Because I had to go to another presentation for 2 individual slides, which I haven't transferred. So now you see unicornate uterus here?
Yes.
Right, okay. The reason I only said theoretically how it looks, but now I'm able to share video. So right now, I'm in the right lateral view of the uterus. Okay. So this is the view, okay? Sorry, left lateral view of the uterus. And I'm playing the video. So there's an I-shaped endometrial chamber. You all can see. Now I turn to the front. Still there is I-shape. It's adenomyosis also. There is extension of endometrium into the myometrium. And then I rotated it this way to the right lateral. You can see still there is a thin endometrial line. So I'll just go back quickly. So the point I'm trying to make is, whichever way you look at it, endometrium eventually will show its narrow finger shape, even in the anterior posterior view, right lateral view, left lateral view. That is the diagnostic of. I just want to share. This lady walked in for an IVF PGD for a boy gender to Bone Hall, Dubai. It's in 2018. Having an 8-year-old or 9-year-old daughter born in a very high quality NICU, 28 weeks, 6 days. She has a normally growing child, I think 1.1 kilo or something. And they did a cesarean, it was a normal delivery, cesarean, but there was no diagnosis why she had a very preterm delivery. Obviously, this is the case. She came for it. So what was my concern? So I did put a stitch, then she had another baby, boy gender. But the point is not to diagnose unicornate uterus, right? Or maybe patient was not told. It's very unlikely a surgeon missed unicornate uterus, or he might have not thought it's not relevant. But cervical incompetency was not prevented. So she had elective non-pregnancy cervical cerclage. That's one point I want to mention from this. Now, if you see endometriosis, you need to understand nowadays, if you do 3D for an endometriosis, this is a typical 2D, and now you do laparoscopy, you just do whatever you are trained to do. You just pull off everything, you do enucleation, you do cautery, whatever. But if you can do 3D even before you do the laparoscopic surgery, you see there are 4 antral follicles between 9 o'clock to 12 o'clock. You can avoid doing too much of diathermy there. You notice the capsule is ruptured and the endometriosis is already invaded. And these are the bowel loops at 12 o'clock, actually 12 to almost until 1 o'clock. These are all bowel loops, omentum, all that. Actually, there is no capsule. So there is a total adherence to omentum and bowel loops between 12 o'clock to 2 o'clock. Here, you need to have a GI surgeon to stay with you to do repair the bowel injury, which may invariably cost. So by knowing 3D, you can plan your endometriotic surgery much better, is the comment that I want to make. So these are the additional things because 3D that brings to play for a reproductive surgeon or fertility enhancing surgeon. And this one, because this is in this presentation, I don't need to revisit back here again. Yeah. These are neighborhood cysts. I was surprised how I can see so many hanging grapes here. And secondly, you can see the endometrium pinching off and growing into the adenomyosis. It's so obvious that even if you correct the T-shaped anomaly, the myometrial endometrial damage is so exhaustive. There is a hysteroscopy image. It looks like a chronic conjunctivitis endometrium if you do dynamic hysteroscopy. Because you're all gynecologists, I want you to know what is dynamic hysteroscopy, what is bimanual ultrasound. Bimanual means you are always using abdominal hand like you used to do bimanual examination long time ago. 20, 30 years ago, all professors were teaching how to bring the abdominal structures towards the pelvis for a complete accurate diagnosis of bimanual examination with hands. Most people don't do that anymore, or for whatever reason. So I do highlight that the your ability to diagnose myometrial pathologies is enhanced. Second, they have autoimmune condition. You must rectify that rather than just giving GnRH analog and doing frozen embryo transfer. This is what a lot of people ask me the question. And the last slide from this presentation is this. When you see 𝗪𝗏, what is the relevance in ART? It is an aberrant mucosa. It is a metaplasia. Normal cuboidal to columnar epithelium here is replaced with mucus producing almost like cervical epithelium. And the mucus, once it is, you give luteal support, you cannot remove the mucus. Don't trust abdominal ultrasound to show the endometrial cavity fluid. It's not possible unless it is a large cavity fluid. So I would believe a lot of endometrial cavity fluid, we are transferring embryo without even diagnosing, without even removing. But if you do see this at the time of a collection, I have 18 case series that was in 𝗀𝗃 IVF in Dubai, where you can do uterine massage, or even during egg collection, a lot of uterine cavity fluid get expelled because myometrial contractions are very strong during egg collection because of the irritation we are causing. Occasionally what I did, I put the probe in the anterior fornix, squeeze the uterus to cause expulsive contractions of the uterus to expel the mucus at the time of egg collection. Of course, I check it again and make sure it's not there. But otherwise, it's very tedious once you give progesterone. Once there is progesterone, you cannot remove uterine cavity fluid. Obviously, if there is 𝗪𝗏, electively, you can just burn the floor of the pit. Of course, you can always do laparoscopic realignment. It's like a scar revision. You can always do just take off, stitch the healthy edges, then you will lose this pyramid-shaped depression. But if you don't do that, you just at least burn the wrong mucus-producing mucosa. That's all you can do. So that's 𝗪𝗏 in relation to ART. That's endometriosis assessment. And whenever you are using catheters, I think I did mention, if you are doing saline scan, you need to occlude external os. You can put 2 to 5 mil and do the scanning. You can keep the catheter in place, TVS probe. You don't need to remove anything. If you want uterine cavity pressure to go up, you need to occlude the internal os. You can use a pediatric Foley's catheter, 𝗧𝗏𝗶𝗃𝗃 cannula, one of the other things. All right. So that ends this presentation. I can go back to my other presentation. I hope people are still having patience to continue to listen to me.
Doctor, we have a lot of them. But what is your thought, sir? Can we close by what time we can close it?
Yeah, so it's up to us. It's 1840. Perhaps I'll take 10 minutes.
Okay, great.
And we'll give it time for the people to have interaction, because that will be 2 hours in total. So let me change the sharing again. So I just want to reconfirm that you are seeing some syringes here. Yes, that is the screen you're seeing.
Yes, doctor.
Right. So anybody interested to change the 𝗧𝗏𝗃𝗃 practice to ultrasound-based tubal patency test? And it's my own technique. You don't need to buy exam gel, which is typically in Dubai is $200. I don't know who is using what in different countries right now. This is the only thing that I'm using, because I know sperm-friendly sperm wash media, which has a high albumin content. So I did a lot of homework in my kitchen to find out that when I'm making egg white whipping, I found a lot of froth. So I thought I'll use it. So because it's sperm wash media, there's albumin containing. I take 5 ml albumin, which is called sperm wash media. I take 5 ml air, take a 3-way connection, take 5 ml of air, and then agitate them. Just mix them 100 times. You get froth, then you inject the froth with the HSG cannula into the uterus. So what you're seeing here is the this part of the tube. All right. So uterus is here, where this white thing is the endometrial chamber. That's the coronal part of the uterus. And what you see is the medial 1/3, middle 1/3, outer 1/3 of the fallopian tube. I showed the front view, but that's on the left side. So you will see the filling and flowing, very brief, small video. Any of you can see it clear enough? Then I'll go forward. Yes?
Yeah, we can see.
Right. So that's easily, you can see live video of that. And the beauty is patient is recording on her own smartphone and send it to me, which means it's not as horribly painful as HSG. Those people who have done HSG, it's almost like going to dentist. They hate the gynecologist for doing HSG. This is the right tube. You can see flow and fill, and this is right and left tubes. You can see the center part of it, left fallopian tube, right fallopian tube. These things you need to learn from me. I published these 100 cases. Only 1 case had bilateral tubal block. 13 people had unilateral tubal block. But when I was in doing residency in Alumni Institute, 30% of my HSGs were always blocked, because my professors told me, my textbooks told me. But when I actually did the hyphosi with air, I found only 1% had bilateral tubal block in Inner London Hospital. Now, this is beyond doubt now. Human reproduction, if you know very well, this is the highest indexed journal, peer-reviewed journal in ART, and they support ultrasound-based tubal patency is recommended. If you see obvious hydrosalpinx, you don't need to think twice. It is hydrosalpinx, but sometimes they're obvious. In 3D, you can see almost like a histopathology or hysterectomy specimen. It's quite obvious, if you know how to do 3D, it just shows up all what you want to do. The main point, now the Doppler, I only pay attention to reverse Doppler, reverse diastolic flow, or totally absent diastolic flow, deep diastolic notch, superficial diastolic notch. We don't pay too much attention for the ART. In PCO, most people find significant reverse diastolic flow, as well as the thrombophilia with plasminogen activator inhibitor. That's why they have a higher implantation rate, higher miscarriage rate. They don't have higher aneuploidy in the oocyte. So I want you to know that. So baseline, I think we discussed already. You need to know how to count the antral follicle. What is the role of ultrasound during ultrasound guided procedures? All right. That's just a completion sake. I put this arbitrary categories in all of this. It will just, I think it's video. It's not video. Yeah. So this is left ovary. That's the right ovary. I fix the ovary so hard. Trust me, iliac vein gets compressed. And that's what my Dr. Tom Matthews, who made me do a collections in Bone Hall, Cambridge, or Peter Princeton, they said, fix the ovary with your muscles, use the lumbricals to perforate the follicle. And you always keep the bevel of the needle at 12 o'clock so the ultrasound can see it. Every one of you are doing a collection, you must see there is a bevel of the needle. Like I showed hysteroscopy, which has got a 30 degrees. And that 30 degrees angle should face the ultrasound probe. Then you can see the tip of the needle very well. Withdraw the needle within the follicle, scan the follicle, anterior and posterior compartment. And when you're emptying, you must scan the follicle. First, you should know the distribution of the follicle. So you're lifting, you're just moving the probe like that, or rotate them, rock them to see the whole dimension of the follicle, and follicle entire amount in the liquid should empty. Only then you take the needle or reposition the needle to another follicle. If the ovary is moving, you should know how to thread it or screw it. Okay? Don't poke it. If you push it, sometimes ovaries poke. So you should know how to fix the ovary. That is the secret of with single puncture collecting most of the follicles and scanning the very slow motion. You should know how to scan the follicle. So practice in slow motion. Lumbricals is the best instruments for us that nature has given us. So that is a screwing technique. Go to the center, withdraw a bit, scan the follicle from front, back, east, west, each follicle. And you perforate the ovary in the widest part to begin with. Don't puncture whatever you see. Go to the middle of the ovary. Some follicles in the east, some west, some in the north, some south. You enter in the center so that with one puncture, you can collect all that. First, to see what is the best way to enter them. And think before you perforate. As soon as you see, don't draw. Unless you see, you may be in the front of the follicle. Follicles are so soft. If you push firmly, the needle can perforate the follicle. So I think this is the other ovary. This is the similar technique. Sometimes I rotate the probe. I do a collection through the 7 o'clock position of the female pelvis. Sometimes at 6 o'clock. Sometimes at 12. Avoiding 3 o'clock and 9 o'clock. But depends on the blood vessels where they are. The needle so that it goes to the center of the follicle. Again, ultrasound guided procedure. When I transfer, my difficult embryo transfer is 2. In the first 3 embryo transfer, it was 100%. So first 3 embryo transfers are mine. None of them got pregnant. So I knew I'm going to lose job in Bone Hall on the same day. But luckily, I continued for 8 years in Bone Hall, Cambridge. So now my difficult embryo transfer rates are roughly 1.8 to 1.9%. So as you can see, I take a lot of meticulous interest to see where the plane of the ultrasound is, plane of the catheter is, and then align that, go in ultra slow motion, eject it. So this is a long video. As you can see, you empty the bubble because we put a bubble in the front, bubble in the back, liquid in the front, which is liquid in the center, which has the embryo. Then you expel the bubbles so that you are sure. So it is a after loading technique or fluid loading technique that I use for embryo transfer, not just squeezing the syringe and holding at the end with a lot of pressure. That creates vibration. It can suck the embryos back. So I use ultrasound even doing hysteroscopy because you get the plane correctly. So you can do ultrasound guided hysteroscopy. You can do ultrasound guided endometrial regeneration techniques, but I do hysteroscopy. All right. And a lot of surgeons use laparoscopy during laparoscopy to get the right plane. They use the TV ultrasound. And it's called vaginal sonography now, vaginal sonography. We put 10-20 ml of saline or gel in the vagina for rectovaginal endometriosis diagnosis and dissection, both even UV fold dissection. Monitoring ultrasound. This is the book. I think about 1,200 copies are sold. It's got all the most of the contents that Dr. Meenal has explained. Coming to early pregnancy, which is the last section. Sometimes you see fibroid, adenomyosis, everything with pregnancy. Sometimes you have miscarriage that you keep missing. Can somebody mute her? Sometimes you see heterotopic pregnancy, but you need to have an index of suspicion. So not only you scan, you see cervix, uterus, cervical canal, endometrial canal, uterine arteries, medial endometrium, central endometrium, lateral endometrium, adnexa, ovary, no fallopian tube should be visible normally. Then above the ovary, below the ovary, no pathology. You go all the way up to the pelvic diaphragm, you go above the ovary. Do it on the opposite side. So, and you always start from the left iliac ovarian fossa vessels and come up to the right ovarian fossa pelvic vessels. You know ovarian fossa, which is made of internal iliac artery, beginning of the superior vesical artery, beginning of the uterine artery, crossing of the obturator nerve, and entering of the ureter from the abdomen to the pelvis. You need to know ovarian fossa anatomy. Your scanning should start right ovarian fossa to left ovarian fossa, east to west. And that's just, I only scan it. I have the videos to show, but we don't have time. So the vertical insertion, rotate probe clockwise, and then go east-west, nothing else. I only rotate probe clockwise 90 degrees and go to the left iliac fossa, right iliac fossa. That's the whole scanning. There are many advantages. I'll just show one I fancy. That's a 5 weeks gestation sac and yolk sac. It's shocking to me. I recorded this in 2018. I have much more superior quality ones now. It looks like a jellyfish to me. This is the level of technology that we have. Then I just want to go to miscarriage. Okay, I did promise I'll finish in time. So this is miscarriage. This lady was running around because it's her 5th IVF with donor eggs. 4 with her own, 5th one with donor eggs with euploid embryos. Very educated Calcutta family, did the donor egg treatment in UK, and she came back here. She refused to accept it's a miscarriage. You can show any reference. Beta HCG level, mean sac diameter, yolk sac diameter, fetal pole shrinking. You can say anything. She doesn't want to accept. But when you show this, that there is no heart in the center, she accepted. So, you know, you don't need to show all this to everybody. What I'm saying is it's easy to see these structures nowadays. Last part of my lecture is training. You must become ISOAG members, right? They teach systematically low intensity, medium intensity, high intensity ERT training program. And there are modules that you can do at your own home convenience. You can learn. And there's something that you learn from me for attending my hands-on workshop anywhere. There are so many 3D animation websites which will tell you how to see the superior, inferior, left sagittal, right sagittal, ovary, all that, even pelvic floor diagnosis. This is the video that I won't have time to follow, but somebody can share it. Anybody want to do future Zoom, they can do with me to extend their learning. You need to have perineal space. It's a crime if you're doing on a school bench ultrasound. I've seen a lot of people are doing it, but they're happy about it. Patients are also happy. They're doing air gymnastics, keeping pillow at the bottom, lifting their pelvis with their own hips. People think it's laughable, but you will never scan the anterior compartment of the pelvis without space, the handle, to depress below the level of the rectum, below the level of anus. I'm improving my skills in levator hiatus dimensions in urogynecology. I keep learning. There's wonderful software in the machine that I use. Levator avulsions, there's one here, and levator dilatations, asymmetric dilatations is all computerized. So urodynamic vulval scanning is a brilliant learning from 𝗀𝗏 that I do. So as promised, I close. This is jackfruit that I ate after I made this yogi. Yogi means sitting and doing yoga meditation. So I'll take a break here just to see if you still have energy to ask question, but ask questions related to the slides that I've shown and anything else which requires proper understanding, because one-word answers are not learning. I don't believe in that. I don't reach this far. I invested 40 years to know what I know. All right. So please learn properly rather than one-word answers in courses and suddenly experimenting with patients. It's not fair. Okay, we are closure now, and then we will talk about anybody who can ask questions by raising hands. Hello?
Doctor, we don't see anybody raising hands, but there are some questions in the inbox. Would you be interested in answering?
Yeah, I'll just read out and read the answers. I saw them. So I stopped sharing and then I'll just go here. Please send algorithms. Yeah. Please WhatsApp me. I know emails sometimes don't download. So my number is there above. Everybody know 00971-567-304147. That's WhatsApp number. I have it on WhatsApp just to send the algorithms.
Sir,
now this question is Zakia, this question is incorrect. Please rectify your question. I didn't say hysteroscopy is not used for polyp. The recording we will share. Email ID is already there. Difestrone, as I said, GnRH analog is much more potent in dropping estrogen and curing polypoid endometrium. If you give Difestrone for 3 months, 6 months, people get depressed, they put on weight, they will have irregular spotting, they can't have sex. I find compliance is very low with dydrogesterone, but otherwise 20 to 30 milligram, day 5 to day 25, you need to give it for 3 to 6 months and then do the contrast care. Polypoid endometrium, as I said before, there are 3. You can give Mirena coil, you can give GnRH analog 11.25 every 3 months times 2 to 3 doses, or dydrogesterone 20 milligram to 30 milligram if she is high BMI, day 5 to day 25, between 3 to 6 months. Now, this is a long question, doctor. You should do a Zoom meeting with me. This is not, I mean, I cannot answer this here. This is just an individual question. You didn't do hysteroscopy for this lady. So without hysteroscopy, you don't know the reason for thin endometrium or thick endometrium. So fundamentally, my answer to this question is you must arrange luteal phase hysteroscopy and you know the reason for thin endometrium, then you can fix it. If it is endometrial sclerosis, no basal endometrium, right? No stem cells in the endometrium, you cannot do anything. Whether I say something or not, nothing will happen. Few words about Doppler parameters for ovulation. I never used it. There is no good evidence to use Dopplers for ovulation. By the way, any doctor who is asking me this question, you do the Doppler 3 times on the same follicle, you will get 3 different readings. In my opinion, I have zero relevance for that. By the way, ovulation you can't see also. Sometimes the follicle, the oocyte comes out, cumulus oocyte complex, like a drop of sweat. The whole grape will be there, only a drop of liquid will come out. It's like you put on a lemon, you put a needle, you squeeze it, only 1 drop of lemon juice comes out. That's called ovulation. Whole lemon is not collapsed. We have this bad dream, every balloon will burst. That's not ovulation. That's very silly way of thinking ovulation. So I don't use any Doppler parameters for ovulation. You give HCG, 36 hours later, ovulation will happen. Yeah, somebody just reminded. I said without patients, there is never a doctor, and without student, there is never a teacher, and without Shishya, there is no guru. That's just a basic approach. So thank you for listening to me. Briefly explain about embryo transfer. Nagesh Kumar, embryo transfer is like uterine sounding. I'm sure you know how to do uterine sounding and ultrasound guidance. Use mock embryo transfer catheter 100 times in a gynae patients. You will be master at it. Okay. All gynae patients buy some 10 mock embryo transfer catheters. Keep doing it under ultrasound guidance. You'll be good at it. I don't need to teach you. Anybody who can put a sound into the uterus can do very good embryo transfer. Mobile number is also there. Sneha Shish. Guidelines for endometrial biopsy prior to ART. Look, I do endometrial biopsy. I have a recurrent miscarriage lecture I can share with you. We do endometrial biopsy to understand endometrial immune profile. We do it to rule out chronic endometritis, and we do it only in the luteal phase. All right? And you do it under hysteroscopy guided biopsy through the access report, or you do a PEPL sample. And the other reason we do endometrial biopsy is for endotrio, 𝗪, ALICE, 𝗂𝗏. That is for recurrent implantation failure. For recurrent miscarriage, we don't do 𝗂𝗏. We do only 𝗪 and ALICE. Anybody interested, please learn properly. This one-word answers will get you nowhere. You will not be confident. Anything, if I just type one-word answer, you will go nowhere. Proliferate phase or luteal phase. Where are we? Yeah, proliferative phase or luteal phase cystoscopy better, points in favor of each. Look, I do luteal phase because imagine a wedded couple are coming to find nice wedding cake. You should have baked the cake with estrogen for 14 days. You should have put icing on the cake for 5 days, and you put cherry on the top, which is called blastocyst implanting. So you should finish baking cake, putting icing, only then you test it to give the Michelin scoring. So there is no role of doing proliferative phase hysteroscopy. But ultrasound, you can do it in the late proliferative phase, because once it is white, due to luteal changes, it's very difficult to see small polyps. So ultrasound, late proliferative, hysteroscopy, luteal phase. Obviously, you should rule out pregnancy. Uterine contractions causing endometrial changes, will it cause implant? Yeah, so whosoever this, Premlata. Now, yes, if you know the research published on fertility sterility, every 1 centimeter away from the fundus, if embryos are implanting, the pregnancy rate drops by 11%. So if you have 3 centimeter dislodged embryo, you lose 33% pregnancy rate. So you must relax the uterus if there is excessive peristalsis, even after 5 days of progesterone. These contractions, mind you, it was in the proliferative phase. I did not do anything. I did not do the recording in the in the luteal phase after progesterone comes. You all know very well, progesterone relaxes uterus. You all know that. So progesterone giving alone can remove it. But if you think it is still there by doing scanning TVS before embryo transfer, there is a protocol for atosibon, oxytocin analog. Ferring distributes it. It's available in India. You have 2 dose regime protocols. You can use them. Share RPL, RF management. My number is so-and-so. Navigation. No, you just say hello to the above number. I will share the presentation. I recommend do Zoom meeting. By just looking at PPT, you can't manage recurrent miscarriages. Exaggerated endometrial place. I told you it can dislodge the deposited embryo. So you need to give tocolysis. Yes, I already said that. Thank you. Yes, we have done 1902. We haven't even had 2 hours of lecture. So it's finished.
Okay. Yeah.
Yeah, anybody write comments? Because in UK, we are supposed to give feedback on what I do. Otherwise, they don't think I've been teaching and training doctors all over the world. So anybody who can put feedback anywhere way you want, the content and the method of delivery and relevance to your practice. These 3 points, if you can just write a comment in anywhere, I'll appreciate, because we are supposed to show what we do to the patients and colleagues for GMC, because I'm a consultant in UK also. Without feedback from colleagues and patients, I will not be practicing every year. That's normal there. It's called revalidation.
Sir, we will be sharing to all the registered delegates your contact numbers, so they can also share the feedback.
Yeah, just on 3 points: the content and the delivery method and the relevance to their practice. Only 3 headings.
Absolutely, we'll do that. Yeah.
Right. Anything else?
So it looks we had I think no more questions. So let me ask.
Nobody commented the quality of images that I showed from Mindray. Can all of you please, can you write, you call it high quality, medium quality, low quality, below average quality? Please write it. You don't need whatever it is, whether it is 2D or 3D, whatever. Please write it, because it's courtesy. Mindray is sponsoring it free of charge. They're bearing my charges and so on. It's fair. We are fair to each other.
Okay, I think, sir, when we are sending this feedback form, even this point it will be uploaded so they can record it as well.
Make it very simple so that they can just circle it and send it. Otherwise, you will never get response.
Absolutely.
Response rate is 80% nil. 20% is the highest response rate on questionnaire surveys. You need to be aware of the data.
We'll do that, sir. We'll do that. So can we take the opportunity?
Yes, Viraz, thank you for your help.
Thank you so much, sir. It is
Who
wonderful
else are there to
session I
thank?
have ever heard so far in my, entire this ultrasound career.
You are looking like a little baby to me. What is your entire career
Yeah,
so far?
whatever little experience I have, but this was a fantastic one. I must say that.
Okay, can I
Yeah.
hold you, Viraj, for a moment? What she
Yeah.
said in the middle of your talk was that she want to visit your clinic in Dubai. I said, I think it's absolutely, everybody want to do that, but rather we would invite you to India where we can, showcase your experience, I think, to hundreds of them. And that's, I think, much more easier also for you.
Yeah, let them express, the delegates express who wants hands-on training, and they should help us to make it a very efficient. I will scan around 15 patients a day. If I'm there with you, you would be scanning around 40 to 50 patients. And then you will say, thank you very much, Dr. Karunarakar. Whatever you learned in 40 years, through 40 patients, you can learn. Because it's not difficult, because it's very easy to learn ultrasound. Anybody who can cut vegetables vertically and horizontally, front to back, anybody who can make salad can do ultrasound.
Yeah. So just, sir, I would like to announce that this workshop thing that we are going to conduct again with, so all the delegates again, thank you so much for joining us. And a small announcement that we are going to conduct this workshop, what sir is talking about. In person, sir would be training on this workshop with all the techniques he has shown. And it's expected to be in Jan or Feb 2025. We will be having close group of like 15 to 20 people max, and the announcement we will make it very soon. And of course, I will also share the eligibility criteria who can attend this workshop. So all the people who have registered for this this webinar will get all the information very soon from us. Okay.
But you
Thank
must
you so much,
declare
sir.
eligibility criteria, not an order for a Mindray machine.
Well, we will also
Yeah.
yeah. Sir, nevertheless, we really wanted to, thank you for this. I think endless, enthusiasm with which, you have given, the passion with which we can able to see, and the kind of images. I think it is the magic in your hand. I think that we can all say the images of Mindray is good, but as always, ultrasound, it's a person behind the machine that makes the difference, a whole lot of difference. So I really seen some amazing image for a very first time, although there are so many NUAs, installed in India, but we have never seen an image of what you should today, in fact. So
obstetrics, you'll get much better images. I have the early pregnancy images of placenta implantation. I can't even breathe when I see my own images, not my images, the machine. 𝗂𝗍 technology, and nobody saw blood vessels in a living baby, network of blood vessels in the yolk sac. Nobody ever demonstrated fetal cranial circulation. I have endless of them. When you're bored with life, I just see those images.
Sir, I think that gives an opportunity to look at another webinar in coming times, not only from the gynecology.
First trimester, first trimester. I'll take on.
Yeah, sure. We will
Second
plan that too.
Separate third trimester.
Yeah, we will plan that too. And in the meantime, sir, I think everybody would be waiting to, to take to the next session, whatever they are planning, and of course you too. We would like to ask Viraj to, felicitate the thanking now. Thank you, sir. Thank you from my side.
Thank you so much, sir.
Yeah,
Thank
yeah.
you. Wonderful
Thank you.
session once again. Yeah. Thank you all the delegates. We will be sharing all the information very soon, and the recordings, of course, because sir has given the permission to, share the recording. That is also very good part. You all can refer it once more time and how many times you want it. And we will share his number, his email ID all through mail. So just check your email box, right? Thank you so much, everyone, and have a good night.
Thank you, sir, once again. And also Dr. Meenal, if she's not there, but our special thanks to her also, and to all the delegates today. Thank you once again.
These comments can be lodged somewhere?
Yes, we can take care of that.
Yes,
Okay, we can just have a screenshot, because
Absolutely.
I need to send at the end of year what I've been doing, sort of thing. All right. Thank you.
Absolutely, sir. Many thanks. Thank you. Thank you so much. And
thank you, sir.
good evening, sir. Bye-bye. Thank you, all the delegates.
Thank you.
Thank you.
Thank you, Dr. Meenal, ma'am. Thank you so much.
Thank you, everyone. Thank you.
Thank you. Thank you, ma'am.
Bye.
Dr. Meenal is also there?
Yeah, the panelist, she is Dr.
Oh,
Meenal.
I think. Okay. Then in that case,
Okay,
madam,
ma'am.
thank you so much
Yeah, good
for
night.
all
Thank
your
you so
support.
much.
Yes. Thank you. Bye.
Thank you. Thank you.